Good morning. Thank you for attending this meeting, and we would like to welcome the experts and our dear friends from Japan. And before the presentation, we would like to have Professor Chong Guangye to give us some words.
Good morning, dear guests. Welcome to Tsinghua University. On behalf of Nuclear Science and Technology Development Center, once again, I'm very excited to have all of you here for this bilateral seminar between Japan and Taiwan. And I remember since the first visit of Professor Ono to Tsinghua University in 2010, we hear the scientists at Tsinghua University and also physicians from Taipei Veteran General Hospital have closely worked with our friends from Japan and on BNCT, the technology. And so in the past, we receive a lot of assistance from our Japanese colleagues, and I appreciate all your help in the past. And I would like to specifically mention that we completed the 300 cases of emergency treatment of BNCT on March 10th. And this is actually a new milestone development for BNCT here in Taiwan. But I want to stress that we cannot do it without the aid from our Japanese colleagues. So I know this bilateral seminar has been going on for several years. But for the past 3 years, the seminar was held due to the pandemic of COVID-19. And we are all very excited to be able to see you here in person this time. And so I, as a director of this center, once again, I would like to thank you for being here and welcome you to together join on this bilateral seminar. And finally, I would like to wish this seminar a big success and hope you enjoy your stay in Taiwan. And we look forward to further future collaboration in the next 20, 30, even 50 years. Thank you very much.
Thank you, Professor Ye. Next, we will invite Professor Koji Ono to give us some words.
Good morning, every participant from Taiwan and Japan. I have been waiting today when we can hold an on-site meeting like this. I can remember the last on-site meeting. It was in 2020, March, in Osaka Medical College. At that time, my university is Osaka Medical College. Now, the Osaka Medical Pharmaceutical Company University. And the name was changed 2 years before. And my BN Center organized a meeting, and COVID-19 already started, however, before the pandemic. During these 3 years, there exists a very big progress in BNCT. It was approved of BNCT itself, the accelerator system, and the BPA drug for BNCT. Sincerely, I say thanks to the company and the researchers related to this BNCT project, Professor Kirihata and he's not here, and he's a Professor Maruhashi, and also is a Professor Tanaka, and all other members related to the clinician, including clinician, head and neck surgeon, and neurosurgeon. In June 2020, we started clinical BNCT for recurrent and or inoperable head and neck cancer patients under the support of public health insurance. The clinical results are quite good and superior to the result of previous official clinical tests. Today, they are presented by a colleague on a recurrent malignant glioma. On the other hand, on recurrent malignant glioma, we are still under negotiation with PMD, the Japanese FDA. I believe that the effect is remarkable. But we are suffering from the difficulty show the statistical insignificance of overall survival time because of the number of the patient is small. We need a clever idea to overcome this difficulty. The data on glioma BNCT by KUR have accumulated. Then very interesting findings have been revealed, so they are present today. In the medical physics field, we have succeeded to improve the irradiation technique and also found a smart idea to increase treatable depths of deep CT tumors. In the biology and chemical field, many studies have been performed in Curie, K-U-R-I. Present name is Kurns, K-U-R-N-S. We are not doing clinical studies by KUR after 2020 because we can do them in an approved accelerator system and also the change of legal control of clinical studies. Therefore, KUR has been essentially used for basic research of BNCT biology, chemistry, and physics. Their fruitful result will be presented today. I am strongly expecting exciting presentation by researchers in Taiwan and advancing the BNCT in both countries. Finally, I express my sincere thanks to researchers in Taiwan, Dr. Chin and Cho, and so on. Thank you very much.
Thank you, Professor Ono, for giving us such an encouraging talk. Okay, next, I would like to invite Professor Feng-In Zhou for give us some few words.
Good morning, all friends. We are very, very excited for see you again. Since 2010, National Tsinghua University, Taipei, Veterinary General Hospital, and Kyoto University study collaboration in BNCT. In the past 12 years, Dr. Ono has given us a lot of help and guidance, both in the basic research and clinical trial. So our THOR BNCT can go smoothly. We still remember when we started treatment the first and second patient in 2010, Dr. Ono personally came to Tsinghua University and give us an on-site guidance. Thank you, Dr. Ono. This is a milestone of cancer treatment in Taiwan. In the present, THOR has completed 300 patient treatment about brain cancer and head and neck cancer. We thank you, Dr. Ono, and many Japanese friends, Professor Kirihata, Tanaka, for giving us a lot of support for our BNCT, reactor-based BNCT. Now, in the future, we plan to develop accelerator-based BNCT. Please give us more support and assistance. We hope that our bilateral cooperation can continue and last forever. Thank you very much.
Thank you, Professor Zhou. Next, I would like to invite Dr. Yi-Wei Chen for giving us some words.
Good morning, everybody from both Japan and Taiwan. Welcome to join our communication conference this time. Especially, we have a very long time. We didn't have a face-to-face meeting. So we appreciate this time. So as a chair and also as a good tradition, I would like to present my greeting in Japanese. 2023年第4回台湾日本放送重視し法則療法交流会議海外の挨拶小野先生をはじめ日本よりご参加の BNCT 学者教授の皆様この度は台湾まで遠路はるばるお越しくださり誠にありがとうございます。この3年間新型コロナウイルスの影響によりなかなか叶いませんでしたが、この度オンラインではなく、このように通常の会議形式で第4回放送重視し法則療法交流会議を開催できますことを心より嬉しく思います。今から3年前の2020年のことを思い返しますと、その時の第2回会議はもともと炭鉱大学で開催を予定しておりました。会議の計画、実行などをハン・ハクシン教授、パン・ボーセン教授が進めてくださっていましたが、残念だから新型コロナウイルスのもう一大拡大のためオンライン形式での会議開催となってしまいました。今回私もとも台湾側が通常会議を再開するになり、清華大学の字で再発足することを選びました。BNCT に革命を起こし、積極的に推進するの清華大学で、今回の会議を開催することを大変意義があると感じております。過去数十年もと間、清華大学の学者、教授の皆様は原子力工学を用いた新たな主要医療技術を培ってこられました。この技術に多くの人々が関わり、大きな費用を投資し、偉大な先輩方より次の時代へと受け継がれています。さらにありがたいことは、日本最先端 BNCT の関連に触れるご機会もいただき、そのおかげで台湾で成果が実りました。これまで数多くの脳腫瘍や頭頸部がんの末期患者を治療し、その方々の人生に新たな温かい光を与えられました。我々は今ここに台湾日本放送重視し法則療法通常会議の再発足を宣言し、今後も台湾と日本ともに腫瘍治療に関わる私たちが継続的に交流を行ってまいりましょう。近い将来、さらに効果的な技術を研究開発し、ますます多くの患者さんのご支援ができますことを願っております。以上、私、 尽意味からの海外の挨拶といたします。ありがとうございます。So please enjoy today's meeting with everybody. Thank you very much.
Thank you, Professor Chen. Before the starting of our session, I would like all of the participants to come to the front and we'll have a group photo. Please come to the front stage. Thank you. Okay. And the first session is clinical medicine. I would like to invite the moderator, Professor Wenliang Luo and Dr. Chunfu Lin.
Good morning. I'm Dr. Lin from Taipei Veterans General Hospital. We'll start the first session. The first speaker is Dr. Satoshi Takeno. Dr. Takeno is a radiation oncologist from Kyoto University Hospital. He will give us a talk about clinical outcome of accelerator-based BNCT therapy on head and neck cancer. Dr. Takeno, please.
Thank you for introduction. I'm Satoshi Takeno from Osaka Medical and Pharmaceutical University. Thank you for giving me the opportunity to have a presentation here. Today, I will talk about the clinical outcome of accelerator-based boron neutron catheter therapy on head and neck cancer. We have no COI. The clinical practice of accelerator-based boron neutron catheter therapy, BNCT, for unresectable locally advanced or locally recurrent head and neck cancer started in June 2020 as an insured treatment in Japan. We have irradiated 130 cases for head and neck cancer in Kansai BNCT Medical Center until January 2023. In this study, we have retrospectively analyzed 54 patients, 55 irradiations treated until January 2022. First, we will show you about the treated patients. We have treated patients with cases in which the entire tumor is expected to be irradiated with approximately 20 Gray equivalent or more, which is considered a curative dose. The calculation of tumor dosimetry in this study were performed under the assumption that TB ratio is 2.5. Exclude cases with high risks, such as carotid artery rupture and infection meningitis. We have treated 54 patients between June 2020 and January 2022. The patient characteristic is here. The age is from 39 to 89. The median is 71 years old. 33 patients were male and 21 were female. Observation period is from 2 to 30 months. The median is 14 months. The treated cancer in lesion are shown in the table. 36 cases were irradiations for primary site, and 20 cases were irradiations for lymph nodes. As for histological type, 47 cases were squamous cell carcinoma, and 7 cases were non-squamous cell carcinoma. The detail is shown in the table. Here is the process of BNCT irradiation. Since the dose in BNCT determined by the relative position between the lesion and the organ at risk, it is difficult to determine whether or not a sufficient dose will be delivered. Moreover, since the radiation port and accelerator is fixed, we need to determine the optimal body position and beam direction before CT simulation. Therefore, a process to make preliminary planning using diagnostic CT image before CT simulation is needed. We call it pre-planning. After determining patient position, a picture of patient body is set and CT image for treating planning is taken in CT simulation process. Based on this CT image, a treatment plan is made. At that time, some minor adjustment to the treatment position may be necessary. To check out the final treatment plan and minor adjustments, a rehearsal is held in the day before irradiation. After this preparation, the irradiation will be conducted. The actual neutron full length depends on the blood boron concentration at the time of irradiation. The blood sample is tested just before irradiation, and actual irradiation time is determined based on this boron concentration. The treatment machine was nuclear by Sumitomo Heavy Industry, and boron compound was steboronin, which is boronophenylalanine by Stella Pharma. The tumor dose was determined by the risk organ dose as shown here. The radiation position was mainly the sitting position during the period we have analyzed in this study. However, from March 2022, An extended collimator on accelerator beamport became available. Therefore, now most cases were irradiated in the supine position. In the sitting position, the patient body was set using fixture as shown on the left image, but there are two problems. The burden of holding the patient body position during irradiation is heavy, and since the CT simulation must be taken in the supine position, there is a possibility that the position of organ in the body may change between CT simulation and irradiation. An extended collimator on accelerator beamport enabled irradiation in supine position. Therefore, it is now possible that the irradiation in BNCT is conducted in similar way to the irradiation in conventional radiotherapy as for patient position. Next, we'd like to present the result of BNCT conducted in our facility. Of the 55 irradiation analyzed in this study, 26 cases were achieved CR and 18 cases were PR, resulting in a response rate of 80%. We think this result is comparable to the result already known in the literature from other institutes. Then we show you the local control rate for the 54 patients treated in our facility. In this study, progression-free survival was defined as time from the date of the irradiation to first documented disease progression or death. Local regional progression-free survival was defined as time from the date of irradiation to first documented disease progression in local regional area. The one-year progression-free survival rate was 49.7%, and the one-year local regional progression-free survival rate was 62.6%. We believe that this is a good local control rate for patients with recurrent or locally advanced head and neck cancer for whom no other effective treatment is available. The overall survival rate was 80.7% at 1 year, as shown in the graph here. However, the median observation period in this study was 14 months, and continuous follow-up is necessary. Here, we present some cases that seem to reflect the characteristic of BNCT. The first case is BNCT for radio-resistant nasopharyngeal cancer. A 40-year-old woman with nasopharyngeal cancer, squamous cell carcinoma, clinical T2 M0M0, was treated with X-ray therapy, 70 gray 35 fractions. The left image is before radiotherapy, and right image is after radiotherapy. The effectiveness of radiotherapy was SD. Since the tumor was evaluated as resistant to radiotherapy, BNCT was performed 2 months after X-ray irradiation. The image on the left showed 1 month after BNCT, and the image on the right shows 6 months after BNCT. 6 months later, the tumor had disappeared, and the patient achieved CR. It has now been about 2 years, and the patient is still undergoing treatment-free follow-up without recurrence. This case shows that BNCT can be effective even for radio-resistant tumor as long as the boron compound is accumulated in the tumor. Next, I'll show you an example of rapid tumor shrinkage by BNCT. The patient was 85-year-old male with buccal mucosa cancer, squamous cell carcinoma. As shown in the left image, a tumor was located from the left buccal mucosa to the hard plate. Just 1 week after BNCT, the tumor had almost disappeared. Now it is about 1 year, and no recurrence has been detected. This case shows rapid tumor shrinkage with BNCT. However, Because of the rapid tumor shrinkage, skin and mucosa defects may often occur in case with skin or mucosa invasion. Therefore, it should be careful when the carotid artery exits close to the tumor with skin or mucosa invasion, since the risk of carotid artery rupture is very high. Based on the result we have shown so far, we then examine the factors that may predict the therapeutic efficacy of BNCT. First, we analyze whether there is a difference in treatment effect depends on histological type, especially for squamous cell carcinoma and non-squamous cell carcinoma. The results are shown here. It is found that the treatment efficacy and local control rate were almost the same for squamous cell carcinoma and non-squamous cell carcinoma. We consider that this may reflect the characteristic of BNCT as a high LAT particle therapy, which can demonstrate therapeutic efficacy regardless of the tissue type, as long as the boron compound is accumulated. Next, we discuss the difference in treatment effectiveness depending on the irradiation target. Here, we examine the difference in local control rate between the presence and absence of lymph node involvement. As shown on the left figure, there is no significant difference in the local regional progression-free survival rate between the cases with and without lymph node lesion. On the other hand, the progression-free survival rate was including progression-free survival rate including earthquake recurrence is also not significantly but lower in case with lymph node involvement, as shown on the right figure. Thus, it can be said that BNCT can be expected to be equally effective for both primary and lymph node lesions. But in the case with lymph node lesion, earthquake recurrence is more likely to occur. The relationship between initial treatment effectiveness and local control rate was also examined as an indicator for post-irradiation follow-up. We analyzed the local regional progression-free survival rate for those in which the treatment effectiveness was CR, PR, and ST respectively. The results show that 1 year local regional progression-free survival rate was 91.3% for patients who achieved CR, indicating a high local control rate. On the other hand, the 1 year local regional progression-free survival rate was only 23.1% for patients whose initial response rate was PR, meaning that recurrence occurred in many cases. One possible hypothesis based on this result is that since BNCT radiation occurs at the cellular level, certain number of cells remain undamaged in cases where the treatment effectiveness is PR, and it may cause recurrence. Therefore, it is necessary to keep the risk of recurrence in mind when following up after irradiation for cases that the tumor has shrunk but does not achieve CR. Here is the summary of this presentation. Thank you for your kind attention.
Dr. Takeno for the wonderful presentation. Is there any questions from the audience?
Thank you for nice presentation and very good discussion. And I have one question. I think the site of the local region recurrence is very important. So the recurrence site is a deep portion or the recurrence portion is a marginal recurrence. If the recurrence portion is almost deeper portion, the treatment protocol should be fixed. I think so. How about?
Thank you for the question. Actually, we haven't analyzed the recurrence position yet, but as Professor Slick said, the recurrence position is very important to improve the protocol. So yes, I want to analyze.
Thank you for an impressive talk. I have one question, is that the overall response rate is much higher than we experienced. And I'm wondering, how do you evaluate the response of this treatment, and also do you use like chemo or other target therapy during the BNCT interval?
So thank you very much. Your question is?
The response rate is very high.
High compared to the
previous experience.
Yes, yes. This is, I mean, clinical practice, the data from clinical practice. So we don't define the after therapy. I mean, the patient from many hospitals to our hospital and conduct BNCT and go back to the original hospital. So I think the patient is many kinds of therapy after BNCT. Some patient is no therapy, and some patient is adjuvant chemotherapy. Also, I think it's possible. Also, we evaluate the response rate. We don't fix the interval to evaluate the response rate. So this response rate is the best response rate after irradiation. And also, it is. I think this response rate is higher than our previous data from using the accelerator based, and it is one of the reasons is the dose is a bit higher than the previous study.
For your response, thank you.
Other questions? Okay, thank you, Dr. Takeno.
Thank you very much.
Now we'll move to the second presentation by Dr. Yi-Wei Chen. Dr. Chen is a good friend of everyone here. He's now working in Department of Heavy Particle and Radiation Oncology in Taipei Veterans General Hospital. He will give us a talk about salvage BNCT for relapsed brainstem tumors.
Okay, good morning, everybody. Next, I would like to try to show our clinical treatment result of a brainstem tumor. As we all know, brainstem tumor is a very intractable disease because we can only use a conventional radiotherapy for this kind of a cancer disease. So after the tumor relapse, we almost have no other treatment options. So in the recent years, because we started to have a BNCT, so we try to use a BNCT to help this kind of patients. And up to now, we already treat for more than 10 patients by compassionate use. So today, I would like to introduce our treatment result to everybody. In our system, as we all know, we have treated a lot of patients of a brain tumor, both for pediatric patients and for adults. And here we would like to thank our neuro-oncology group in Taipei Veteran General Hospital, especially the neurosurgeon, Dr. Lin, and our oncologist, Dr. Lee. Today, they all attend to our conference. And we work together as a group so we can help a lot of brain tumor patients. And up to now, we use BNCT for brain tumor patients for more than 200, both for pediatric and adults. So now we have a lot of experience accumulation, so we can share our experience to all the audience today. Here I would like to introduce the latest status of BNCT in Taiwan now. Because we started to use BNCT as a clinical trial in 2010. Our first is a clinical trial for recurrent head and neck cancer. And since 2017, we use BNCT as a compassionate use. So we use BNCT for both head and neck cancer and brain tumor. And just like what our Professor Ye mentioned, last week we completed 300 patients by compassionate use of BNCT. So we would like to share our experience. Last year, as we all know, Dr. X is a very famous Japanese drama. And in this season, we can see in Japan, BNCT already become a very standard cancer treatment, just like a chemical surgery. So we feel envious about this because we hope in Taiwan, in the near future, we can also have this kind of system, just like an accelerator-based BNCT. And just like what I mentioned, up to now, we already use BNCT for both head and neck cancer patients and brain tumor patients. And up to now, we treat both clinical trial and compassionate use. We already treat for more than 350 patients. And most are brain tumor and head and neck cancer patients. And because up to now, we use BNCT as an emergent treatment, so we have to make an application first to our government. After the TFDA approval, we can start to help this kind of patients. And we can still help a lot of patients from foreign countries, including from America, Japan, Brazil, Australia, Singapore, and China. So in the near future, we hope to treat for more than global patients. And up to now, this patient, by compassionate use, they have to pay by themselves. Today, I would like to try to introduce how we use BNCT for brainstem tumors. Because we all know brainstem tumors is very difficult to treat, and most of them are high-grade glioma. And the patient number age is around 7 to 9 years. And brainstem is also a very important portion of our central nervous system. So if we cannot treat this kind of tumor effectively, patient will lose their life very soon. So we hope use some useful treatment to help this kind of patients. And as we all know, brainstem tumor in the old time was also called diffuse intrinsic pontine glioma, DIPG. But since 2016, it changed the name as diffuse midline glioma. And in Taiwan now, every year we try to help many pediatric patients. And as our statistic report, every year we have 500 to 550 patients, pediatric patients, cancer patients. And we have only 100 to 150 for brain tumors. And diffuse midline glioma is one group of them. And usually we can only use radiotherapy for this kind of patients. And every year, we only have around 10 patients in Taiwan's population. So this is a case of very young kids, and their parents try to help them. But finally, we cannot prolong their life because conventional treatment cannot help this kind of disease. In my department, we try to make some analysis for brainstem tumors, and we found only radiation is a prognostic factor. Only radiation can help this kind of a patient because it usually unresectable status. So this is a young kid, 6 years old girl, and we can see is a diffuse tumor located in the Ponting area. And they have a lot of symptoms associated with their tumor location. And now in Taipei Veteran General Hospital, after conventional treatment, we found the tumor can be only controlled for 6 to 8 months. And after 6 to 8 months, the tumor recurred again, and the recurrence rate is around 100%. And after the conventional radiotherapy for this group of patients, we have no other aggressive salvage treatment options. So we found maybe BNCT can play an important role for this kind of patients. So we will refer our patient to Tsinghua University Reactor Center. And up to now, we use the BPA infusion protocol just like in Kyoto University. So we will provide 500 milligram BPA per kilogram body weight for this group of patients. And in our group, we found that because if we use large doses for this group of patients, especially for pediatric patient will have a lot of sufferings. So we try to reduce the dose and use a multi-fractionation strategy. So we provide 2 fractionation treatment within 1 month for this group of patients with low dose. And each patient will have 5 to 10 gray equivalent each time, the mean dose. And the total we provide no more than 20 gray equivalent. Because this protocol is by the experience we used before. Because if we provide 2 high doses once for this group of pediatric patient will have very serious symptoms. Because all our patients were cared by our oncologist, Dr. Lee. So she can provide us a lot of the experience sharing, and we can try to adjust our treatment. So up to now, this is our treatment protocol for pediatric brainstem tumor patient. And we also adjust our dose constraint. So up to now, if we use this constraint, the patient can have a very safe and effective treatment. And this treatment planning system is by new SOAR station. We use this new treatment planning system for more than 100 patients. And up to now, it's a very reliable system. So we thank to our engineer, Professor Dr. Pei and Mr. Wu to help this kind of assistance. Then we can provide a high quality treatment for this group of patients. So we can see we use this treatment planning system to make a treatment planning. And this is the positioning, how we deliver our neutron beam. This is also, we can see the dose rate distribution in different BPA concentration level. And usually we make 2 treatment planning, and we make the comparison, and we choose the best one for our patients. So we can see compare the 2 treatment planning, and we will have a discussion before we started the treatment. And finally, we will find the best one for our patients. So we also publish our data, and we treat brainstem tumor patients for more than 10. And the pediatric patient, we also treat for more than 10. Because we found pediatric patient is a fragile patients. But BNCT is a very safe and effective, especially for pediatric brain tumor patients. So we found it's maybe in the future is a good indication for this group of patients. So we have the data for the patient characteristics. And this is the only patient we have the side effect, brain necrosis. This is not because of we use BNCT. This young kid, before we start BNCT, he received hypofractionation treatment in the foreign countries. Because in a COVID-19 time, so the foreign country tried to use the hypofractionation treatment to shorten the treatment course. But as we all know, for the CNS tumor, if we use hypofractionation, we will follow this patient and find some long-term side effect, just like a radiation necrosis. So we do not recommend it to use a hypofractionation strategy for this group of patients. And in our previous experience, if we use a BNCT 2 fractionation within 1 month, we can see the tumor shrink, and the patient have very good quality of life. So we found it's a useful treatment for this group of patients. And in our system, our engineer will help us to make a simulation for the young kids. Sometimes we will play the animation in the ceiling or in the wall to help the patient to relieve the anxious mood. So we can treat this BNCT very smoothly. So we can see we play the animations. And this patient can have a very good treatment response. This is as an adult for the diffuse midline glioma. And after BNCT, we can see we use a PET, and the uptake of a BPA decrease. So we think BNCT is a useful treatment for the brainstem tumor patients. This is a focal brainstem tumor because it's under the unresectable status. Even patients suffer from recurrence, we can still use a BNCT to help the patients. And this is a Spanish patient. Because they got the information, we can help brainstem tumor patients. So they refer the patient to our system. Although this case is a low-grade glioma, but they still have very poor prognosis. So we try to help this patient with BNCT twice. So we can see after BNCT, the tumor shrank with very good response. Because before the BNCT, we use a FBPA PET, the tumor uptake BPA. So we have a confidence to help this group of patients. So it was also reported for international media. And this is a very special case. We use a BNCT for metastatic, not the primary brainstem tumor. This case, the primary is breast cancer, and he suffered from a recurrence in brainstem. The patient already received a whole brain irradiation, so they have no space for conventional treatment. So she was referred for BNCT. And as you can see, after we use a BNCT 2 fraction in 1 month strategy, a tumor shrank. But unfortunately, the tumor recurred after 6 months. So we try to use a second course of BNCT to help this patient, and the tumor shrank again. And this patient has very good quality of life, have no neurological deficit. So we think BNCT is a very useful treatment. And recently, we also published our treatment data because we use the BNCT to help the pediatric brainstem tumor patients. And in these 6 patients, we found that BNCT can prolong the survival to 3 to 6 months. And this is a very good treatment effectiveness because after the recurrence of a brainstem tumor, usually we have no good and aggressive treatment option. So BNCT can help this group of patients. We have the statistical calculation, and we found that BNCT can help this group of patients. So we can see the image, follow image 1 month after BNCT, the tumor shrank. So up to now, we have the confidence to use a BNCT to help brainstem cases. Although the treatment can only prolong 3 to 6 months, But we still believe if we can use a multi-fractionation with low dose, maybe we can help this group of patients in the future. So we try to refine our technique and maybe design a clinical trial in the future to help this group of patients. And finally, I would like to introduce a slam dunk because it's an animation in my college period. And this is a very meaningful saying. If you give up, BNCT will be ended here. So we will follow this saying. So thank you for your attention this time. Thank you.
Thank you, Professor Chen. Is there any question from the audience?
Thank you very much for a wonderful lecture. I'm Dr. Furuse from Osaka Medical Pharmaceutical University. So I want to make sure, so you choose 2-fraction BNCT. After 2-fraction BNCT, there are no radiation necrosis, right? Okay, do you have any other serious adverse event about 2-fraction BNCT?
No.
Okay, then I can't catch your table, so how long is overall survival about DIPG?
Our survival for the overall survival after BNCT is 6 months, median, the 6 months, and the recurrence-free is about 2.3 months.
Do you usually use bevacizumab after BNCT?
Yes, sure, definitely.
Last question. So we have never treated DIPG with BNCT because, you know, re-irradiation is kind of risky for brainstem regions. So do you recommend?
But up to now, we find it's safe. It's safe. But because there's no other treatment options, so maybe BNCT, if we use it carefully, it can help this group of patients, even for pediatric patients.
Thank you very much.
Maybe sometimes more than 6 or 7.
May I ask you?
Yes. Sure.
Thank you for your great presentation. I am Dr. Nihei also from Osaka. Your presentation, you use multi-fractionation BNCT. We don't realize it in Osaka. It's very reasonable and good idea. But how is the direction of the neutron beam? You use the same direction or opposite direction?
Okay. Because we use, sometimes we can use from the posterior, single portal. And because we have 2 fractionation, so sometimes we use 2 oblique. One time is from left and the other time is from right. So they can have a more good homogeneous
distribution.
Dose distribution.
I see. Thank you. Another question is, brainstem tumor is very deep-sited tumor. So can you achieve the sufficient dose to the tumor?
Yes. Because before we started treatment, we will use our TPS to make the calculation. We found that maybe pediatric patient can have enough dose distribution. But for adult patient, maybe sometimes the depth is too long. Yeah, so maybe we have to make more fractionation to compensate these problems.
You showed a brainstem metastasis in adult patient?
Yes, yes.
How was that case?
You mean a portal or direction?
No, dose. tumor dose?
Dose the same, 5 to 10 each time.
That was for the purpose of palliation.
Yes, yes.
I see.
Yeah,
Thank you.
because the brainstem is also very sensitive. We cannot use a larger dose. It's too dangerous.
Thank you.
Yes, yes. Yes, sure, sure. Pediatric patient also has lower, we found. Yes, yes. Different from some other brain tumor. Sometimes we can see the TN ratio for more than 4 or 5. Yeah, but in brainstem, we found that the TN ratio is low, around 2.5.
So is there any question from the audience? All right.
Thank you.
We thank the Professor Chen's spectacular lecture. Our next speaker is the Professor Motomasa Furuse. Professor Furuse is from the Osaka Medical and Pharmaceutical University. His topic will be the survival benefit of BNCT with add-on bevacizumab for recurrent malignant glioma.
Good morning, ladies and gentlemen. First of all, thank you very much for giving me such a great opportunity to have my presentation here. So this is my first time to participate in this meeting, and also my first time to visit Taiwan. And especially today is my birthday. Thank you very much. Anyway, my talk today relates to a clinical study of BNCT with bevacizumab for recurrent malignant glioma. As you know, BNCT is a tumor-selective particle radiation therapy, so BNCT could be applicable to recurrent malignant glioma, which has already undergone 60-gray radiation in the initial treatment. But BNCT still has a problem to occur radiation injury for recurrent malignant glioma. This is our initial study of BNCT using the combination of BSH and BPA or BPA alone. So the median survival time was 10.8 months for recurrent malignant glioma and 9.6 months for recurrent glioblastoma. So they were not bad at that time, but of treated 22 recurrent malignant glioma patients, 3 patients died due to radiation necrosis. This serious adverse event should not be ignored. So vascular arterial growth factor is expressed not only tumor tissue, but also radiation injury. VEGF progresses angiogenesis and increases vascular permeability, resulting in formation of vasogenic edema and the leakage of contrast media on MRI, which is mimicking tumor progression. VEGF was markedly expressed around the radiation necrosis in immunohistochemistry of anti-VEGF antibody, reactive astrocytes here in a boundary between the necrotic core and the normal brain tissue. So VEGF is expressed in radiation necrosis. Bevacizumab, a monoclonal anti-VEGF antibody, was effective on radiation necrosis. We reported the prospective multi-center trial in which patients with symptomatic radiation necrosis were treated with bevacizumab.
in this study, 78.9% of patients reduced periregional edema, and 42.1% of patients improved performance status after bevacizumab treatment. The maximum volume reduction of periregional edema was 63% from the baseline. So we conducted a clinical study of BNCT with add-on bevacizumab for recurrent malignant glioma patients and evaluated efficacy and safety of this combination therapy. So we prospectively enrolled recurrent malignant glioma patients with the combination therapy between June 2013 and September 2018. The Kyoto University Research Reactor was used for neutron source. BPA was used as a boron compound. BPA concentration in tumor tissue was estimated using a tumor blood concentration ratio of 3.5. Neutron irradiation was planned as normal brain and scalp dose, less than 11 to 13 gray equivalent. Bevacizumab was initiated 1 to 4 weeks after BNCT. Bevacizumab of 10 milligram per kilogram was administered every 2 to 3 weeks until disease progression, adverse event, or patient wish for discontinuation. So in this study, we could not perform molecular diagnosis and could not categorize tumor according to WHO 2016 brain tumor classification. So initially diagnosed glioblastoma, which was compatible to IDH1 type glioblastoma, was categorized as primary glioblastoma. Other malignant glioma, including secondary glioblastoma or grade 3 glioma, was categorized as non-primary glioblastoma. We elucidated the survival effects of BNCT and add-on bevacizumab and compared patient survival with our historical cohort who were treated with bevacizumab alone after tumor relapse. Here are results. This table shows patient demographics. There are 14 primary glioblastoma and 11 non-primary glioblastoma. First relapse at BNCT in 8 patients, second relapse in 10 patients, and the third relapse in 7 patients. The median tumor volume was 35 milliliter, and the median duration to BNCT from the initial diagnosis was 18.5 months. The median overall survival was 21.4 months for primary glioblastoma and 73.6 months for non-primary glioblastoma. The median progression-free survival was 8.3 months for primary glioblastoma and 15.6 months for non-primary glioblastoma. This waterfall plot shows tumor response using the sum of perpendicular diameters of enhanced region on MRI. The objective response rate was 72% with 6 complete remission cases. The median time to maximum decrease from BNCT was 2.3 months. Now, I'd like to show an illustrative case. A 44-year-old male had left parietal primary glioblastoma. Tumor was recurred 8.8 months from the initial surgery. Then BNCT was applied and bevacizumab treatment was initiated. Complete remission was achieved 3 months after BNCT. However, he had the second relapse
8.2 months after BNCT, even if bevacizumab treatment was continued. Then he underwent bevacizumab plus temozolomide, but finally he died 36.7 months after BNCT due to a CSF dissemination. The clinical factors associated with overall survival was analyzed with Cox proportional hazard model. Only the tumor volume less than 44 milliliter was significantly associated with long survival. 60% of patients had any adverse events, and there were 6 adverse events more than grade 3. Grade 4 proteinuria in 4 patients, grade 5 myocardial infarction in 1 patient, and grade 5 meningitis in 1 patient. Then we compared survival benefit of combination therapy with survival with our historical cohort using bevacizumab alone. The overall survival for the combination group was longer than bevacizumab alone, but the difference did not reach statistical significance. The progression-free survival for the combination therapy was also longer than bevacizumab alone, but there was no statistical significance. So there are many reports to combine radiotherapy with bevacizumab for high-grade glioma. This is a systematic review of the combination therapy. The cumulative analysis did not show survival benefit, but the frequency of radiation necrosis significantly reduced. This is the phase 2 study of accelerator-based BNCT in Japan. The median overall survival for recurrent glioblastoma was 18.9 months. However, the median progression-free survival was only within 1 month. This swim approach shows clinical course of all patients. Black arrows show the overall survival, and the red points show the timing of progression disease, recurrence. So as you can see, many patients had early progression, but in these patients, some patients here or here showed long survival. So this discrepancy, so long survival and early progression could be a progression disease on MRI might include pseudo-progression or radiation necrosis. This study did not allow use of bevacizumab after BNCT until disease progression. So after red point, after recurrence, bevacizumab was allowed to use. So actually, most of patients underwent bevacizumab therapy after recurrence. So as all you know, Taiwan BNCT group reported salvage BNCT for malignant brain tumor, life-threatening end-stage brain tumor patients who are treated with BNCT. So this table compared BNCT studies in Taiwan and Japan. So study design was completely different, and also definition of TN ratio was different. BPA administration was close, and but the definition of prescribed dose and timing of bevacizumab were also different between the 2 studies. The rate of poor prognostic patients was same,
tumor volume was much larger in Taiwan. The main tumor dose was higher in Japan. So tumor response and progression-free survival were better in Taiwan, but survival was better in Japan. So the background of this study were completely different, so they should not be compared, but I think that discrepancy between the tumor response and the survival could be associated with timing of bevacizumab. In conclusion, 25 recurrent malignant glioma patients treated with combination therapy of BNCT and bevacizumab. The median progression-free survival and overall survival from BNCT for primary glioblastoma were 8.3 months and 21.4 months, respectively. Comparison with the phase 2 study of accelerator-based BNCT, add-on bevacizumab extended progression-free survival by means of suppressing pseudoprogression or radiation necrosis, I think. The median progression-free survival and overall survival were longer in recurrent glioblastoma patients treated with bevacizumab and add-on BNCT and add-on bevacizumab than those treated with bevacizumab alone. But there's no statistically significant difference, but the number of patients could be small. The results of this study showed that BNCT with add-on bevacizumab has a possibility of effective treatment for recurrent malignant glioma. So the results of this study has been already published in Japanese Journal of Clinical Oncology last year. So if you are interested in, please check it out. So thank you for your attention.
Oh, thank you, Furuse Sensei. Wish you an unforgettable birthday today. Okay, is there any question from our audience? Please.
Okay, thank you very much. That's a very wonderful presentation. I'm Hiroki Nakamura from Tokyo Tech. And you showed about the comparison between the Taiwan's group and your group for the third page. Could you show me the slide between the, and not this one, the other one, survival, overall, And overall survival is your university is longer compared to the Taiwan treatment. And how about the quality of life of the patient?
Thank you for a good question. So as you can see the swimmer plot, yellow line means patient keeping performance status.
Mm-hmm.
So
even though
some of patients were
short, right?
half time of our survival, they kept their status, but some of patients were very short.
But even if you count the bar, or the yellow bar, so this is also longer compared to the Taiwan result, right? So I think your case is those higher dose compared to Taiwan's group, but it's also better, you mean?
But the Taiwan group, has no radiation necrosis, so maybe low dose BNCT could suppress radiation injuries, but
contribution of overall survival is kind of low, right?
But for the patient, which is better? I'm not familiar to this one, but how do you think about for the patient?
Yeah, inclusion patient
yeah.
are completely different. So,
Okay. Our study in Taiwan is for compassionate use. It's different from in Japan. It's a clinical trial. So at the very first, we recruit all kinds of patients, including a terminal stage or poor performance and a larger tumor dose. Everything we recruit. So because it's the first experience for a brain tumor patient by BNCT, so we try to lower the BNCT dose at first. So it's different from the clinical trial. But in the near future, we will to conduct a clinical trial. Yes, we will escalate the dose. Very soon, maybe 1 or 2 months later, we will start our clinical trial in Taiwan.
What do you think about the result, between these two?
But I think it's not the same standard, so we cannot compare these two. But in the near future, after we do the clinical trial with the similar inclusion criteria and exclusion criteria, maybe we can make a comparison with each other.
Yeah, thank you very much.
I have one question. What kind of criteria do you use for the response? And this is the first question. And the second question is, will using the bevacizumab affect the response? Like, because the perifocal edema will be less, but will it have a possibility that it will mask the progression of the tumor? Thank you.
So this graph shows tumor response. So we use the SPD, the sum of perpendicular diameter of contrast enhanced tumor. Then 50% of decrease, it's a PR, partial response, partial remission, and tumor is gone, it's a complete remission on MRI. Answers. And the next question is...
Second question is, will bevacizumab influence the response? Will it mask the progression of the tumor?
Most of the patients improved their MRI, but I don't know how it truly effect on tumor itself. But MRI is very better than those before bevacizumab.
Thank you. Thank you for your answer.
Okay, is there any question? All right, thank you.
Thank you very much.
Furuse Sensei. Our next speaker will be the Yuki Tamari Sensei. He is from the Institute for Integrated Radiation and Nuclear Science, Kyoto Prefecture University of Medicine. His topic will be the influence of BNCT on normal liver tissue. どうぞ。
I'm Yuki Tamari from Kyoto Prefecture University of Medicine. Today, I would like to talk about the effect of BNCT on normal liver tissue. This paper has already published in Radiation research. Advances in high-precision radiotherapy and particle radiotherapy have provided therapeutics to normals while reducing their effect on normal liver tissue, resulting in best advanced control of liver tissue tumors. However, some patients after radiotherapy develop radiation-induced liver disease, RILD, such as fatigue, abdominal pain, ascites, jaundice, and hepatomegaly. In RILD, fibrosis develops in the liver sinusoid at an early stage, and then the end of the hepatic pain is occluded. Recent studies suggested that activation of the hedgehog signal pathway, which is essential for embryogenesis and brain and spinal cord differentiation and proliferation, plays a vital role in the pathogenesis of fibrosis in multiple tumors. A series of events have been reported after irradiating the entire liver with 6-gray X-rays. According to reports, fat accumulation in hepatocytes and subsequent apoptosis resulted in the activation of the hedgehog signaling pathway as an acute reaction in 1 week, and sinusoidal fibrosis occurred in 10 weeks. They concluded that this mouse model has potential as a resource for investigating the pathogenic mechanism of RILD in the early stage and late stages. Boron neutron capsule therapy is a kind of radiotherapy. The mechanism by which BNCT kills tumor cells is based on the nuclear reaction between thermal neutrons and boron-10. When boron drugs selectively accumulate in tumor cells, they can be treated while preserving normal cells. Liver cancer is not currently a candidate for BNCT because it cannot supply sufficient amounts of thermal neutrons to draw deep liver tumors. However, multiple liver tumors become attractive candidates for BNCT if larger amounts of boron succeed in selectively accumulating. In clinical studies of BNCT for malignant glioma and head and neck cancer, the amount of thermal neutron is determined by the dose of normal brain tumors and normal oral mucosa, respectively. To drive BNCT clinical trials for liver cancers, the effect of BNCT on normal liver tissue needs to be investigated. The purpose of this study is to confirm that the X-ray demonstrated sequence of events leads to RILD in mice is BNCT reproducible. The mice used were 6 weeks old female C57 BL6. 3% LBPA fructose was injected subcutaneously as a bone drug. ICP-AES was used to measure the boron concentration, and the boron concentration was calculated from the following mucose formula. Neutron ionization was performed at the heavy water facility of Institute for Integrated Radiation and Nuclear, Kyoto University. The neutron flux is written here. The physical dose was calculated by adding the boron dose, nitrogen dose, hydrogen dose, and gamma ray dose. The reverse of neutron irradiated mice were removed after 1 week and 6 months and fixed in 4% formaldehyde solution. Reverse controlled 1 week after neutron irradiation were HE stained to investigate fat accumulation. Reverse corrected 6 months after neutron irradiation were Mason trichrome stained to investigate fibrosis. To quantify triglyceride in the liver tissue, the liver was corrected 1 week after neutron irradiation and analyzed using a quantification kit. In addition, Western blotting was used to determine the expression level of sonic hedgehog protein. First, we investigate fat accumulation in the liver when exposed to X-ray. 1 week after X-ray radiation, the liver was fixed and HE stained. The results showed that fat droplets increased with each increase in X-ray dose from 0 gray, 2 gray, 5 gray, and 10 gray. This is a quantitative result of the boron concentration. Liver and blood boron levels are measured 2 and 3 hours after administration of LBPA. In the past, it was being demonstrated that the amount of the change in boron concentration between 2 and 3 hours after administration of LBPA is small. And in this study, neutron irradiation was performed for 1 hour from 2 hours after LBPA. Physical dose were shown here. These are results of HE staining neutron irradiation. It can be seen that the liver tissue subjected to BNCT has increased the fat accumulation, fat droplets compared to the control and neutron irradiation alone. When this quantified, the liver tissue of BNCT group had an increase in fat droplets about 3.5 times that of control and neutron irradiation alone. This is a quantitative result of triglyceride. It is clear that triglyceride is increased in the liver tissue of BNCT group. From the results of HE staining and the quantitative results of triglycerides, it was found that BNCT increased the damage to the liver. These are results of evaluation of fibrosis by mass trichrome staining. It can be seen that the stroma of the liver tissue of BNCT group is dyed blue and fibrosis is progressing compared to the control of and neutron irradiation alone. The amount of fibrosis in the liver tissue of BNCT group was twice that of the control and 1.6 times that of neutron irradiation group. On the other hand, no significant differences was observed in the liver tissue that was only irradiated with neutron compared to the controls. This result indicates that fat accumulation by BNCT causes fibrosis. These are the results of investigating the expression level of sonic hedgehog protein by Western blotting. The expression level of sonic hedgehog in the hepatocytes of BNCT group was steadily increased compared to the control, which was about 2.3 times. This result indicates that hedgehog protein activation is closely associated with BNCT-induced liver fibrosis. This study reveals that BNCT induces fat deposition in hepatocytes 1 week after irradiation activates the hedgehog pathway and results in the liver fibrosis as a later effect. This result indicates that this sequence of events can be used to investigate the pathogenic mechanism in the early and late stages of RILD after BNCT. Currently, accelerator for BNCT are being developed all over the world. And it is expected that the indication for trunk tumors such as liver tumors expand in the future. Previous studies of BNCT in the liver have used hepatocyte genotoxicity as an indicator of BNCT adverse events. However, it is questionable whether the use of genotoxicity as a measure of adverse events with BNCT is appropriate as an acute clinical endpoint. It has been reported that the series of reactions mediated by hedgehog protein are gender specific. Since only female mice were used in this study, similar validation is needed for male mice. And investigation is needed with BSH, which has a different tissue distribution than BPA. Furthermore, in connection with further studies, future studies on the development of new boron drugs, it has indicated that liver fat deposition and activation of the hedgehog pathway observed in early stages of neutron irradiation are useful as surrogate markers for late adverse events, liver fibrosis. This study's results indicated that damage to normal hepatocytes caused by BNCT enhanced the expression of sonic hedgehog, leading to hepatic fibrosis. This study suggests that hepatocellular fat accumulation and hedgehog signaling activation can be used as an index to assess adverse events in BNCT, which may improve the assessment of normal liver in BNCT for abdominal tumors. Thank you for your attention.
Thank you, Tamari Sensei. Is there any question from our audience? Yeah, please.
From your report, your presentation, we can see we're using BPA as a boron carrier for treated liver cancer. The boron concentration in liver seems equal to the blood. So if we irradiation, BNCT irradiation the liver normal tissue, it will be damaged. So if we want to get an effective treatment for liver cancer, we need to develop a new boron drug. Thus, we can decrease the liver dose and increase the liver tumor dose for BNCT. Do you mean this?
Oh, yeah. Question?
You mean you're using BPA as a boron drug for treated liver cancer, and then if you want to get enough dose for treated liver cancer, the normal liver will get a lot of radiation dose and will be damaged. So we should develop a new boron drug that can higher accumulation in the liver tumor, and the normal liver tissue can reduce. Those can reduce. Do you mean we need to develop a new boron drug for BNCT of liver cancer?
I think that it's your comment on. Okay, I agree with your opinion absolutely. So, but I think the peripheral tumor in the liver, I think the candidate of the BPA BNCT. So, I think the this is a basic study is a very important for developing the new boron drugs for boron compound. So he presented the result of the HE staining following the X-ray. So we have the plan to calculate the CB factor for boron. Endpoint is liver fibrosis. So he will do it in the future, I think.
Correct. You did only one those points,
Those point here, yes.
there is no relationship according to, yeah. That is very important. 2.5 or 3.5 is only 1 point data.
Yes.
Yeah. I would like to know how much those should be reduced to make the same response when we combine the BPA or BSH in comparison with neutron alone or control or X-ray. It's a very, very difficult, a lot of work which we need. Yeah.
I'm Dr. Nihe from Osaka. Thank you for your presentation. As Dr. Ono mentioned, I'd like to know about the difference of liver injury between BNCT and X-ray irradiation. There may be much data of liver injury after X-ray irradiation. Do you have some comments about the difference between BNCT and X-ray?
X-ray data is
Thank you for nice question. I think the mechanism of the liver injury using the X-ray and BNCT is the same. So he presented the data. So the mechanism is the same, but the in case of the BNCT, the thermal neutron cannot penetrate the deep portion. It is good in case of the BNCT because the deep portion of the liver tissue is spared in BNCT. But so I think in some cases, multiple metastatic tumors in the shallow portion, BNCT will be a good candidate. I think so. Thank you very much.
Thank you. Is there any questions? All right. We thank for the Tamari Sensei's speech. And we will end of this session. And next session will begin around 11 o'clock. Thank you.
Okay. Next, we'll have a coffee break, and we prepare some coffee and tea and some snacks in the left of this conference room. And the restroom is in the next building, and we have some instruction on the wall. Okay, so we will come back for the next session at 11 o'clock. Thank you. We will start the next session of medical physics. Here, I would like to invite the moderator, Professor Tanaka Hiroki and Professor Hui-Yu Tsai.
Good morning, ladies and gentlemen. After a short break, I hope you enjoy the coffee and the snack. So I hope these things can cheer you up. So right now we move to the section on medical physics related to BNCT. So I'm Hui-Yu Tsai from National Tsinghua University, and I handle the medical physics education program in Tsinghua University. And right now I would like to hand over to the colleague.
My name is Hiroki Tanaka from Kyoto University. I am a medical physicist in Kyoto University as a medical physicist. And it is a great honor to be here. And we would like to special thanks to Dr. Chen and scientific community of this meeting. So could you start the session?
Okay, so right now we move to our first speaker. So Professor Pei, yeah.
Sorry, it's my work. So let me introduce about first speaker is Jinja Pei from the Tsinghua University, my friend. So could you start your presentation?
Okay, thank you, Mr. Chairman. Good morning, everyone. On behalf of our research group, I take great pleasure to address here with a paper on BNCT treatment irradiation, status and the development of an integrated platform new source station for BNCT online monitoring at THOR. I'm going to cover BNCT treatment irradiation status at THOR, new source station at THOR, and some conclusion. Firstly, BNCT treatment irradiation status at THOR. Tsinghua Open Pool Reactor is a 2 megawatt rated power research reactor activated in 1961. It started its commissioning after the completion of BNCT facility construction in 2005. Since then, many scientists and researchers of different specialties will draw attention to BNCT for relative investigation, such as animal or cell irradiation at National Tsinghua University. The BNCT facility at THOR successfully moved to the preclinical trial study and clinical trials in 2010. The BNCT facility of THOR is presently the only reactor-based BNCT facility worldwide used for clinical lab treat patients in the past decades and is available to the BNCT community overall. Okay, this is the BNCT treatment irradiation statistic. And THOR BNCT has performed 2 clinical trials for recurrent head and neck and head and neck cancer, and just 300 salvage treatments for many recurrent and head and neck cancer, malignant brain tumor, or other indications before March 10, 2023. Today, there are 260 patients were treated at the facility, and among them, 75 patients received multi-irradiation and 347 irradiation types, including 190 brain tumors and 153 head and neck cancers, and 4 other cancers has been executed in total for BNCT treatment at THOR. The treatment irradiation increased quickly with salvage BNCT of breast cancer. introduced after 2017. Moreover, there are more than 200 treatment irradiation accomplished between 2020 and 2022. All patients are treated by the doctors from Taipei Veteran General Hospital. The BNCT facility of THR is presently the only reactor-based BNCT facility worldwide that is used for clinical purpose and that has been treating patients in the past decade and is available to the BNCT community all over the world. Apart from Taiwan, patients are currently from Australia, mainland China, Japan, Singapore, Brazil, Spain, Italy, and the United States of America. The numerous treatment activity has gathered interest and stimulated many scientists and researchers to conduct further approaches in BNCT animal and cell studies at NTHU or other universities in Taiwan. As a result, in the last recent 3 years, the accumulated radiobiology data on BNCT clinical treatment and animal and cell irradiation has been rapidly increasing at THR BNCT facility. The BNCT facility includes many essential systems, such as epithermal neutron beam system, online monitoring system, QA/QC system, positioning system, and the boron concentration measurement system, and the treatment plan system. The neutrons of THR BNCT are monitored by a LabVIEW-based PC program, which called OMS BNCT, that was previously developed in 2006 to upgrade the data acquisition capability and the system hardware of the BNCT facility to meet the requirements of users. An advanced platform with online monitoring, precise transmission, high storage rate, and the data analysis ability is crucial. It will make BNCT radiobiology investigation before, during, and after clinical animal and cell irradiation more efficiently. Especially for BNCT clinical treatment, the synchronization of relevant irradiation data can highly promote the collaboration of medical groups to achieve the quality objectives of therapy. Therefore, we aim to develop an integrated platform named New Source Station, or New Source. Is with multi-function of OMS QA/QC parameter input from boron concentration and the TPS systems for dose prescription or recording before BNCT clinical animal and the cell irradiation, and the data analysis for further BNCT study at THR. The reactor power level is also displayed on the new source to help the BNCT supervisor and the operator control the overall conditions of the THR BNCT operation. And the multiple users can co-work simultaneously by PCs through the internal network, even when working with different aspects of THR. In addition to the data acquisition and the display of the neutron beam counting rates data query function, which exports data in CSV format, is also included in new source to help the further analysis and the research study of any specific case in the futures. Authentications ability with user approval and the authorization function is designed for the management of THR, and the daily backup is performed every day at midnight for server data protection. I will not cover too much detail. If you have, the detail can be found in our recent publication, just published about two days before. And the design of new source is based on the procedures of BNCT treatment or experiment as THOR. There are two subflows for BNCT application treatment. One is treatment flow, the other is experiment flow. After registration or application and with the completion of corresponding data input, the operator can use new source to monitor the irradiation status of the reactor to reactor control system. The treatment or experiment data is saved in a database server for further recovery, analysis, and study. This figure shows the logical flow of new source for BNCT monitoring. As can be seen, the configuration includes THOR, AP, neutrons from the core, a counter system, and ion chamber and current of QA, QC data acquisition, and industrial PC treatment of experiment data input by wireless or Ethernet system, personal computer of operators and Ethernet systems, and internal wireless or Ethernet connection was chosen for the purpose of data security, given that is patient information that is being collected. In the new source online monitor system treatment flow window, it has 11 blocks. You see there are patient's data, system information, monitor information, channel information, irradiation information, wide range power window, and the wide range neutron counting rate window, and also power chart, and show range power windows, and reactor power, target dose, and the gamma dose rate of irradiation room. And also 10 is show range neutron counting rate window and deliver dose windows. And the auto scaling function is set for the irradiation parameter charts to enable the automatic display scaling. BNCT irradiation at THOR requires a close collaboration between the supervisor, the operator, the doctor, and the technician. With new source online monitor system, they can all access the information and thus complete the work smoothly. The left figure presents the major counting rates of a BNCT radiation session, simultaneously recorded by new source and the online monitor system BNCT. Over the right figure is the prescribed dose of those two systems. From the comparisons of the output, the results show very good consistency. And this figure describes the blood concentration, the blood boron concentration of salvage patient measured by ICP-OES input from the boron concentration measurement group through new source during the treatment irradiation. After the BPA injection, 3 patient blood samples at 1 hour, 2 hours, and after the irradiation are individually taken and measured by the boron concentration measurement group and transmit to the supervisor and the operator in the BNCT control room for the dose prescription and the final dose evaluation. And this is the irradiation treatment plan dialogue of a salvage irradiation performed by new source. There are 6 preliminary treatment plans designed by the TPS physicists using THBNCT plan in this case. As shown, there are 1 field treatment plan, F1, with 30 and 40 ppm boron concentration, and the two field treatment prints, BF1 and BF2, with 30 and 40 ppm boron concentration imported from THBNCT print to new source. After detailed discussion and comparison of print A and the print B, the two field treatment prints B were selected by the medical doctor, by Dr. Chen, as radiation prints. And the average blood boron concentration of the patient was 35. You can see very small here, 35.75 ppm at a 2-hour injection, and the irradiation power was set to 1.7 megawatt. Due to the boron concentration exceeding 35 ppm, prem BF1 and prem BF2 with 40 ppm boron concentration was therefore chosen as the irradiation prints in this case. After the accomplishment of BNCT treatment irradiation, the pin bar you will see here show us then that the status is changed from irradiation to final. I see here. Okay. And this figure shows the new source online monitors ongoing display of BNCT treatment irradiation performed recently. When the arrangement is ready for BNCT treatment irradiation, the new source online monitor system can be started by pressing the virtual button. This is the virtual button. And after you press, then the screen will, you can press this with the mouse here. And after that, only the selection icon of the irradiation treatment training system record icon of the stopped is, you will see the function key is different with the other I showed before. And then the status bar in block 2 here is changed from standby mode to irradiation mode, and the BNCT related parameters are shown in block 3 and 2 to block 11. Moreover, in block 3, the monitor information of BNCT radiation, including praying dose constraint, the remaining prescription dose, the corrected prescription dose, the percentage of reactor time, and the remaining radiation time appears on the monitor. The BNCT supervisor and the operator can synchronize the watch those parameters in the BNCT control room and the THOR control room to control irradiation. And this multi-block display mode is a noteworthy improvement for monitoring purpose and help the BNCT supervisor and the operators obtain the regional and the global irradiation information needed to set the correct operation condition. This figure shows the pop-up monitoring window of the new source that the doctor sees during the salvage BNCT irradiation of a patient. It's a panel-like window mixed with digit number that show the key irradiation information of BNCT irradiation treatment. The attending physician and the accompanying family can use this practical information, in particular the remaining type of irradiation, to support the patient during the irradiation treatment. This figure is a new source recording of a mouse experiment after BNCT irradiation. Due to the time is limited, so please read the detail in our recent publication in Life Journal. So finally, I would like to make some conclusions. New source is successfully established at THOR in this work. With new source, BNCT radiobiology investigation will be efficiently performed, and the thorough data storage and analysis system of BNCT treatment or experiments can thus be systematically built up for the further investigation on BNCT at THOR. Function extension of new source can be carried out upon the requirements of the users. The design of new source is a good model of Neutron monitoring system that can be utilized on an accelerator-based BNCT facility. And thank you for your attention.
Thank you for Pei-san. It is a very important new platform tool for BNCT. Any question or comment from audience? I have two questions about what kind of online monitor do you use? You use a Neutron monitor.
Neutron monitor.
What kind of? Because in Japan, we don't have a ionization chamber for the online Neutron monitor system. We just use proton current to decide the dose limited.
Yeah.
So
we use fission chamber, three
fission
fission
chamber.
Fission chamber to monitor.
3 chamber. Fission chamber. Okay.
In chambers. Those, chambers. I had to put I have to write the details of the monitoring system in my paper.
Okay.
So there are 3 fission chambers to put it just near the assets of the BNCT B9 tube.
Yeah.
We then we connect the signal from that one to our monitor room. So we get the signal from that.
Okay.
So in the USC, they are the
in the middle of the chart is output of ionization chamber.
Yes, output. This is the output. This is the output of fission chambers. Yeah.
Okay, thank you. So because in Japan, we cannot use fission material inside of the hospital. So do you have some idea for the neutron monitoring system, such as Boron-10 ionization chamber or something else?
Condensation ion chamber can be used. I don't know if it contains fissile material in that kind of detector. I don't know. Maybe we can discuss later.
Yes, right. Okay, thank you. Okay. Any question or comment? Yes.
I would like to know, you have shown that the radiation dose during the treatment, right? And you can do the control of the tumor dose. So I would like to know what is the cut point or what is the index you use to terminate the irradiation? According to the tumor dose.
Here. We have put the round down value here. Because in this case, you can see the constraint dose is brain, normal brain. It's about 1,200 centigrade here. Then the irradiation time, then because we have to input many information for these patients, then the system has been put the irradiation time and showed it on on the screen here. Then the operator can check the irradiation and also the percentage of the dose, then we can run down. In this case, the reference time is about 14 minutes. Okay. And after the irradiation, you will also can remain time here. And if the percentage of the dose reach around 95%, then this color bar will turn into yellow color, then to red color. You can also put the gamma dose rate of the irradiation. Okay, you will turn into this color, so the operator can run down. Can be to run down according to the signal from the monitor. Okay.
Okay, thank you.
Okay, thank you for again, Dr. Pei. Thank you very much. So let's move on next.
Okay, now we would like to move to next presentation. So the speaker is Professor Naonori Hu from Osaka Medical and Pharmaceutical University. And today, he would like to share his experience on advancement in the beam collimation of an accelerator-based neutron sources. So Professor Hu, please.
Hello. Yes. Hello. Thank you for the introduction. My name is Naonori, and I'm a medical physicist working at the Kansai BNC Medical Center under Professor Ono. Before I start, I would just like to say thank you to Dr. Chen, the Taiwanese colleagues, and the sponsors as well for putting together a wonderful conference and also a very lovely dinner last night, and excellent hospitality. So I would like to say thank you before I start. So today I'll be sort of introducing a little bit about our center and some of the advancements that we have been doing for the beam collimation to improve and increase for patient application for BNCT. So some of this study was supported by the JSMP funding. So we'll talk about three main topics. The first one will be some of the extended collimator where Dr. Takeno mentioned earlier in his presentation. And secondly, about improvement for deep-seated tumors, which is a bit of a problem or a difficulty for BNCT. And thirdly, filter for sort of multiple targets we have been sort of working on. So firstly, the extended collimator for head and neck cancer. Before we start our center, Osaka Medical and Pharmaceutical University, I think most of you are very well aware of our center, so I won't talk too much about it. So we are located in Takatsuki City, which is not too far from Osaka, central Osaka. So we're very, very close to the main city of Osaka. So our center is inside the university hospital. So BNCT, as you all know, it's approved in Japan since 2020 in June, so almost 2.5 years ago. Currently, BNCT is approved in Japan for head and neck unresectable, locally advanced head and neck cancer. We currently treat with a single fraction BNCT, and the irradiation time is approximately about 30 to 60, maximum 1 hour irradiation time. So it's very important to keep the irradiation time as short as possible because of the patient burden, and the patient's fixation setup is very crucial for BNCT. So just a little bit about the neutron characteristics. So with high energy X-rays, the primary photon beam travels in a straight line before it hits the patient, whereas for neutrons, the accelerator-based neutrons, they sort of spread out all over the place before they hit the patient. So the neutron intensity actually declines or reduces as the distance away from the patient quite dramatically. So it's very important to place the patient close to the beam port to reduce the irradiation time. So our center, we have two systems. We have the couch system for primarily more for the brain treatment BNCT, and we also have the chair system where the patient can sit down on the chair, and this is primarily for sort of head and neck patients. However, as Dr. Takeno mentioned earlier, for head and neck patients in the past, before this extended collimator was developed, most of the patients were treated in a sitting position. And for BNCT, as you're all aware, the beam does not rotate, so the patient has to rotate towards the beam field. So if you wanted to treat with the couch system, the patient will have to be really close to the wall, so that there's a lot of pain in the shoulders, or if the patient is sitting down for a long time, the patient setup or patient movement happens, and the radiation time is about 1 hour, so it's a lot of burden on the patient. So the overall uncertainty of patient setup is very high for sitting BNCT. So therefore, we developed a extended collimator for head and neck patients, so patients can receive BNCT in a much more comfortable position in a sleeping or, a couch setting. So this is the standard collimator that was initially approved at 2020, and we developed two different types of collimators, where it's 5 centimeters and 10 centimeters away from the wall. And we performed beam performance, beam data collection in collaboration with Sumitomo Heavy Industries. And the application and the data was submitted, and this was approved by the PMDA, which is the FDA approved, similar to FDA in America, for clinical use in March of 2022. So we performed characteristic tests inside a water fountain to make sure the simulation data were correct to the measurement. So we performed thermal neutron flux measurement inside the water phantom using gold foil activation method, and we used TLDs to measure the gamma ray distribution. So this is the result. For the left, we have the 5 centimeter extended collimator, and on the right, we have the 10 centimeter extended collimator. And we've centered it under the same condition. So with the standard collimator, we have this a 5 centimeter gap, and we compared it to the 5 centimeter extended collimator. And with the 10 centimeter, we extended the phantom away 10 centimeters away from the wall, and we compared it with the extended collimator. And you can see the blue line indicates the extended collimator, and you can see almost approximately double the neutron intensity with the extended collimator. So therefore, we performed a treatment plan using a dummy patient model. And on the left, we have a standard collimator with a 10 centimeter large air gap. And on the right, we have a 10 centimeter extended collimator with a very small gap. And you can see the planning 3D view on the bottom here. And we performed a treatment plan of a mock parotid cancer, left side parotid cancer, using the two different collimators. And the dose was prescribed to the mucosal membrane of Dmax of 12 gray. And we compared the dose to the tumor and the dose to the OAR along with the irradiation time. So here's the results. On the top, we have the standard collimator 3-dose distribution. On the bottom, we have the extended collimator. And you can see the low dose, which is this aqua blue line, which is a 5% dose line. And you can see a very noticeable decrease in the spread out of the neutron beam with the extended collimator. And also a large difference in the treatment time. With the extended collimator with a 10 centimeter air gap, it takes about over 100 minutes to treat this patient. However, with this new extended collimator, for the same setup, we can have within 44 minutes, so within 1 hour, we can treat the patient. And finally, the dose, the DVH distribution, you can see the top right on the tumour dose. And you can see a slight increase in the tumour dose with the extended collimator. And on the OARs, all of the OARs were reduced with the extended collimator. So we can see the results three-dimensionally. The spread out of the unwanted neutrons were very much reduced with extended collimator. Just a little bit of statistics. So before this collimator, we were treating almost all patients using the chair system. However, after the approval of the extended collimator, almost majority of the patients can now be treated in the couch position, the supine position. So a very much more comfortable position for the patient. And with all these 95 patients, they were all treated with the extended collimator, so 100% usage of the collimator once it's been approved. So to summarize this chapter, patients can now receive head and neck cancer in a much, much more comfortable position. And the radiation time is very much reduced. The setup time and the setup uncertainty is almost reduced as well. And also the dose to the tumour is increased and the OAR is also decreased as well. So it's a very good outcome that we've found with this extended collimator. And we're currently developing different types of collimators to suit different needs. So now, second topic, I'll talk on the filter for dose improvement of deep-seated tumours, which is some of the issues that were raised before for the brainstem cases. So this Sumitomo Heavy Industry, this new QR BNCT system, which is the same system that's been installed at Kyoto University, this has been approved as a medical device since 2020 of March. It's an accelerator-based system with a 30 MeV proton beam striking a beryllium target. And you can see the neutron energy spectrum distribution between the cyclotron-based, accelerator-based, and the reactor-based system. And you can see the accelerator system is more suited to be treated for deep-seated tumours because of slightly higher energy neutrons. So, however, with the radiation for deep-seated tumours, which was from before, so one of the methods to treat deep-seated tumours is to use multi-field irradiation techniques. However, our current system only has a single irradiation port, and to treat multiple fields in a single fraction, we need to reposition the patient. So we need to take into consideration the setup time and also the exposure to staff irradiation and also the BPA infusion time we need to take into account as well. So there's a lot of challenges for multi-field BNCT in our current system. So we need to investigate a system to easily to treat with a single radiation field. So this is so the optimum neutron energy for a deep-seated tumor has been reported to be approximately around 40 kilo electron volts. So on the right here we see monoenergetic neutrons distribution, and starting from low neutrons to high energy sort of neutrons. But if the neutron energy is too high, the surface dose increases dramatically. So although you do get some advantage in the depth, but the surface dose also very much increases as well. So therefore, we need to sort of aim to get a neutron beam around 10 kilo electron volts or 10 to 40 kilo electron volts to get an optimum sort of neutron energy. So just to compare our system, which is the blue line, which is the nuclear dose spectrum, comparing it with some of the other accelerators in Japan, so with the Tsukuba system and the system in Nagoya. And you can see the nuclear system has a slightly higher, a peak at a slightly higher neutron energy. So comparing it to these three sort of different accelerators, we can see that nuclear has a slight advantage over the other two to treat deep-seated tumours. However, with so the system is designed to to deliver neutron energies around 10 to 40 keV. However, after the neutron exits the BSA, the beam shaping assembly, there's a collimator that sort of collimates the neutron field before it hits the patient. So therefore, some of these low energy neutrons are slightly increased before it exits the patient, before it exits the collimator. So therefore, we want to reduce these. Yes, so we want to reduce these low energy neutrons to get a much higher, or a higher mean energy of neutrons. So one method we thought about how to reduce these low energy neutrons is to place a thin sheet of lithium-6, which has a very high cross-section to low energy neutrons. So we place a thin lithium filter into the collimator before it exits and hits the patient. So we want to ultimately reduce these low energy neutrons and just to get a high flux of 10 kV kiloelectron volt neutrons. So we performed a Monte Carlo simulation to see what sort of thickness we wanted to achieve to get an optimum dose distribution. And we used a Monte Carlo code FITS, particle heavy ion transport code, to see the distribution inside a uniform phantom with the standard sort of parameters that we used in the clinic. Just to look in the results, so we see, of course, obvious results, but when we increase the filter thickness, the normalized neutron, thermal neutron flux around the central axis effectively went deeper into the patient or deeper into the phantom. However, one of the drawbacks is, of course, if you increase the filter thickness, the increase in the treatment time also increases as well. So we wanted to find a good balance between the thickness and the treatment time. And we selected a thickness of 5 millimeters, which was just enough so we can treat the patient within 1 hour. So we selected a 5 millimeter thickness filter, and we performed experimental measurements. We developed the filter, which is the 5 millimeter lithium-6 enriched filter. And we placed this inside the collimator, and we performed experimental measurements inside the water phantom. Similarly to before, we looked at the thermal neutron flux and the gamma neutron dose. And we see with the left side is the thermal neutron flux, in the middle is the gamma ray dose rate, and then we have the off-axis thermal neutron flux at different depths. And we can see under all different conditions, the simulations very much closely matched the experimental measurements inside the water phantom. So we were very, the simulation results and the manufacturing of the filter, we were very happy with, and the composition of the material was can be placed into the model. So then we performed a distribution, a 3D distribution inside, using the filter. So the left side is one with no filter, and the right distribution is verified with the filter. And you can see the isodose distribution a little bit went deeper into the patient. And we placed 4 different tumors at 4 centimeters, 6 centimeters, 8 centimeters, and 1 at off-axis to see how much the dose would change. And we saw a 25% increase in the minimum dose at the tumor located at 8 centimeters of depth, and also a 34% increase in the tumor at off-axis as well. So not only did the depth distribution get better, but also at off-axis as well. So finally, I'll just talk about the multi-dose improvement for multiple targets. And this is something that we've recently just been working on, so we don't have a lot of results yet, but just we would like to sort of talk about what we were sort of working on. So currently in Japan, the maximum aperture size approved for clinical use is 15 centimeters for the standard collimator and 12 centimeters for the extended collimator. And one of the basic conditions for application of BNCT is the target, or the targets, must lie within the irradiation field. So the targets must lie within this collimator size. That's what's been reported in Japan. But however, obviously patients, there are very different types of patients with the treatment of like multiple targets using a single field may be difficult because the OAR overwhelms the dose at the targets. So if we have a look at, for example, the neutron beam profile for a single target, it's very suitable because the target is within the regions. However, if we have 2 targets and the organ at risk is at the middle of the high peak of the neutron flux, a lot of these patients cannot be treated with the current system. So therefore, for example, this is just an example of a patient. We can see the red line indicates the irradiation field, the aperture size, and we have two tumors up in the pharotracheal lymph node, and one down here as well. And it just lies outside the radiation field. So according to the protocol, this patient may not be suitable for BNCT. So therefore, we designed a sort of a neutron beam shaper to sort of shape the different profile beam coming out of into the patient. And we are currently working on the different types of materials and composition and density as well, but to reduce the cost, we looked at something for polyethylene mixture with lithium fluoride. So the polyethylene is used to reduce the high energy sort of fast neutrons, and we used a lithium fluoride to shield or cut off the low energy neutrons. So therefore, so the basic idea is for the neutron beam profile from the collimator coming out, so we place this neutron beam shaper in between the patient and the field, and essentially we get a profile like so, where the middle peak is reduced and the horns are increased. So therefore, we can produce high dose to the two multiple target tumors while reducing the dose at the OAR. So we did a very simple study of that patient before. So on the left, we have the dose distribution without the shaper, and on the right, we have placed this shaper in between the patient and to sort of spread, to block the center while increasing the dose at either sides of the patient. So this purple is the mucosal membrane, which is what we don't want to irradiate for head and neck patients. So we reduce the dose at the mucosal membrane while increasing the dose at the either end of the tumors. So you can see on the top right, the tumor one, without this field, without the shaper, the dose will be less than 20 gray, which is what we have targeted for curable dose. But with the shaper in field, we can dramatically increase the dose to the tumor. However, there is one disadvantage. The treatment time does increase because we're adding the neutron flux ultimately reduces overall. So to deliver 12 gray equivalent to the mucosal membrane, the treatment time increased up by 50%. So from 30 minutes to about 45 minutes. So that's one advantage that we need to investigate further. So finally, the basic applications for conditions for BNCT for related to physics is our protocol is within 7 to 8 centimeters from the skin surface, and the lesion must lie within the radiation aperture. However, with this new, using this new filters, we may be able to treat up to 8 to 9 centimeters, and also the tumors not necessarily do not have to lie within the radiation field. Thank you very much.
Thank you, Professor Hu. Now we open for questions. Please.
Regarding the patient positioning, because we usually use a horizontal field for BNCT, the fixed beam, and do you think there are any advantage if we have another vertical beam? And what is the difficulties when constructing a vertical beam in the physics point of view?
Yes, thank you very much for your question. Yes, a vertical beam. In Japan, there is also one facility that uses a vertical beam line. I think it very much depends on the patient, where the tumor is located for the patient. And for certain, for example, for this particular patient, this one may be more suitable with using a vertical beam line, so the patient can just lie on the bed and the beam will just come straight down. Whereas with the horizontal, our system, the patient would need to lie 90 degrees. So it very much depends on the patient, the location of the tumor. But I think both systems do have the advantage and disadvantage. Yeah, I think both maybe there are two beam ports in one system might be better, but yeah, I think both systems do have their pros and cons, but yes.
Okay, another question? Yeah, please.
Thank you for this wonderful presentation. I I want to ask, you designed two collimator that in length, one is standard and the other is the length of 10 centimeters, then in length, right? And what is your next plan to design another different collimator? Because 10 centimeters is still too short for many patients, according to our experience here.
Yes, thank you very much. And it's exactly what you have mentioned. 10 centimeters is, we still need something longer. And currently we're looking at something more like 15 centimeters, but also changing the collimator diameter. Currently we only have 12 centimeter diameter aperture, but we want to maybe increase that or maybe decrease that depending on the patient. But yes, we need 10 centimeters is still too short, and we want something a little bit longer. And we are looking to investigate what the optimum design to get the best outcome. Yes. Yes, thank you very much. Yeah, well, I'll take that into consideration and work on 15 centimeters, yes.
Okay, please.
Thank you for nice presentation. I think I have one question about the third filters. This filter is very interesting. So this filter can be used as optimized by patient because the filter is I think available for the whole scalp irradiation for angiosarcomas. So it's a fixed shape. I think the composition of the polyethylene and lithium filter is customized patient to patient.
Yes, it's exactly as you mentioned. We need to optimize this for each patient. So there's different designs and different thickness and different composition that we need to consider for different patients. Depending on the tumor might be for a shallow tumor or deep tumor, we need to change the thickness of the filter. So it's still in progress, and we are trying to figure out how to figure out what the optimum design is. Yes, thank you.
Okay, thank you, Professor Hu. Now I hand over to Professor Tanaka.
So last speaker is Pei-Wen Lee-san from Tsinghua University, National Tsinghua University. Her topics is using biological index as treatment plan, evaluation in boron neutron capture therapy. If okay, please start your presentation.
Professors, ladies and gentlemen, good morning. I am Pei-Wen Lee, a research assistant in BNCT Center, National Tsinghua University. Today, I am going to show the topic is using biological indices as treatment plan evaluation in boron neutral capture therapy. This is the outline of my speech. First, I will introduce how to evaluate BNCT treatment plan currently, and talk about the evaluation index in radiation therapy. Next, we'll show the cases and how to calculate these indices in this study. then present the evaluation index results, validation, and the other BNCT index. Final part is the conclusion and the future work. Let's start from the introduction. During the workflow of BNCT in Taiwan, National Tsinghua University will prepare 2 treatment plans before BNCT irradiation and have a meeting with radiation oncology group from Taipei Veterans General Hospital. During the meeting, doctor will compare the dose volume histogram, average dose, minimum dose, and the maximum dose of tumor between these 2 plans and choose the better one. However, when these plans are similar in those physical index, it will be difficult to make a decision. So we need more plan evaluation indices to solve this problem. Plan evaluation index can be divided into 2 categories. One is physical index, and another is biological index. Most common physical indices are average, minimum, maximum dose, dose volume histogram, homogeneity, conformity, and gradient. The first 2 are used to evaluate BNCT treatment plans in Taiwan, and the last 3 indices are usually for the radiation therapy, which dose distribution is very uniform and conformal, such as INRT, VNAT, and SRS. Biological indices included generalized equivalent uniform dose, tumor control probability, and the normal tissue complication probability. We try to apply biological indices on BNCT and compare the benefits of physical and biological indices to determine which indices are more suitable for BNCT treatment plan evaluation. Next is the cases and the calculated methods. First part is an overview of these cases. There were 10 cases with glioblastoma in our study. This table shows the characteristics and the clinical follow-up index of them. The average age was 48.7. Male and female both were 5 cases. MR examination was performed 3 months after BNCT on each case, and the response assessment in neuro-oncology criteria was used to assess the tumor response. Complete response, partial response, and stable disease were 4 and 2 cases respectively. Overall survival was defined as the time elapsed from the day of intervention to the date of death or the last follow-up. The overall survival of 5 cases were more than 1 year. Second part shows the evaluation index calculation. The BNCT treatment parameters were inputted into the treatment planning system to calculate the physical indices, included average, minimum, maximum dose, and the homogeneity index. Since the model of biological index was based on conventional photon therapy, so we converted the BNCT dose to equivalent dose in 2 grade per fraction, EQD2. And then we calculate the GEUD and the TCP. After all the plan evaluation indices were calculated, we analyzed the correlation with clinical follow-up indices that are tumor response and the overall survival. How to calculate these 4 indices will be introduced in the following content. The equation of these 4 indices are listed here. I will introduce them one by one. First is homogeneity index. Homogeneity index is the ratio of maximum dose to minimum dose of tumor. If homogeneity index close to 1, that means uniform dose distribution in tumor. Second is equivalent dose in 2 grade per fraction. BNCT gives high dose to tumor in single fraction. However, conventional photon therapy is 2 grade per fraction. The biological indices we used in this study are based on conventional photon therapy. So we use the concept of biologically effective dose to convert BNCT dose into EQD2. In the equation, capital D is the total dose, and the D is the fractionated dose. The alpha-beta ratio is dependent on early or late responding tissue. Third is the generalized equivalent uniform dose. BNCT dose distribution is very non-uniform in tumor. Convert non-uniform dose distribution into uniform dose, and both of them have the same radiobiological effect. Then the uniform dose is GUD, which was proposed by Neutron in 1999. In the equation, N is the number of vessels in the region of interest. A value is a tissue-specific parameter, depends on normal organ or tumor. According to a definition proposed from Neutron, A value is positive for normal organ and negative for tumor. Fourth is the tumor control probability. Tumor control probability is a sigmoid shape curve and is related to D50 and gamma. D50 is the dose at which 50% of tumors are controlled, and the gamma is the slope at D50 of the TCP curve, and it depends on early or late responding tissue. There are 4 parameters in these equations. For alpha-beta ratio, the papers we surveyed are all assigned 10 for tumor. The A value in GUD. These papers assumed -10 or -8 for tumor, and the AAPN report suggests that A value is equal to -10 for tumor. According to a study about radiation sensitivity of glioblastoma in 1999, the D50 is 47.2 gram, and the last, Neutron suggests that gamma is 2 for tumor. All the equations and the parameter setting we used in this study are summarized here. We are going to show the results, validation, and other index. In the validation part, we validate evaluation index by tumor response and the overall survival, and find out the suitable dose cut point. This page shows the clinical follow-up indices and the plan evaluation indices among 10 cases. After that, we analyze the correlation between these indices. First, we focus on the tumor response. According to the tumor response, we divided the cases into 2 groups. There were 4 cases in group CR and 6 cases in group PR and SD. Next, we used box plots to distinguish the 2 groups in average dose, minimum dose, maximum dose, homogeneity index, GUD, and TCP. Group CR is red box, and the group PR and SD is blue. The box plot shows that the 2 groups can be separated in minimum dose, GUD, and TCP. The table presents the mean value of each index and the differences between them. We found that the differences of these 3 indexes are more than 100%. Second, we focus on overall survival. If groups according to whether the overall survival is more than 1 year, there were 5 cases in each group. There were the box plots. Overall survival over than 1 year was marked in red and another is blue. We found that there was more discrimination in GUD and TCP. Then the differences were also more than 100%. And there still had some discrimination in minimum dose and the differences of mean value was the highest among the physical indices. After that, we used Kaplan-Meier survival curve to analyze the discrimination in average dose, minimum dose, GEUD, and the TCP. Used different cut points in each index to divide the cases into two groups. If used average dose to separate two groups, the survival curve cannot be separated clearly. In addition, all the p-values were more than 0.05. However, if used minimum dose to separate two groups, all the survival curve can be separated. And when the cut point is at grade equivalent, there is statistical significance. Then this page shows the survival curve in GEUD and the TCP. The survival curve can also be separated in GEUD, and when the cut point is 15 grade equivalent, there is the statistical significance too. Finally, TCP cannot separate the curves, and the p-value were all greater than 0.05. All the parameters we used in TCP equation are referred to the data from conventional photon therapy. This may cause the poor performance of TCP. During the experiment, there were two major limitations in this study. First, we need more cases to validate the evaluation method. Second, the parameters in TCP model are based on conventional photon therapy, so the evaluation result was not well. This may be better if the parameters are based on BNCT technology. Besides the minimum dose and the GEUD we mentioned above, Professor Ono proposed a new index for BNCT, that is absolute biological effectiveness, ABE. They use the histopathological slice to measure the nucleocytoplasmic ratio. And there was a very strong correlation between NC ratio and D0. The correlation is Ono's equation. Calculate ABE factor by the NC ratio and Ono's equation. Then the ABE dose was determined by multiplying the ABE factor with the boron dose. In order to prove the benefit of ABE, there were 9 patients with head and neck cancer in this study, and also divided into 2 groups according to the tumor response. White box is group CR, and the gray box is non-CR. The box plot shows that using ABE dose, differences in the dose is very clear between 2 groups. So we believe that re-examining the way of BNCT treatment plan evaluation is very important. Maybe we can try to use these new indices, like minimum dose, GEUD, and ABE dose. Finally is the conclusion and the future work of this study. According to a box plot and the Kaplan-Meier survival curve, we can see that minimum dose and the GEUD are more suitable for BNCT treatment plan evaluation. And when the minimum dose overlay 8 grade equivalent or GEUD overlay 15 grade equivalent, BNCT will be more beneficial. In the future, we will collect more cases to verify whether minimum dose and the GEUD are suitable parameters for BNCT treatment plan evaluation. Up to now, we have accomplished over 300 BNCT treatments. By analyzing these treatments and other radiobiological experiments, TCP parameters for BNCT may be developed. In addition, because the ABE dose only apply on head and neck cancer currently, we will try to apply the ABE dose to glioblastoma cases and check the performance. There are the references in our study. This is the end of my speech. Thank you for listening.
Thank you for the nice presentation, and I'm happy to hear that the ABE dose is effective for the biological index. So, any question or comment from audience? Yes, please.
Thank you for your nice presentation. My question may not be your topic, but you showed 4 complete response patients, but 2 patients died 6 to 7 months after BNCT, right? You have 4 complete response patients, but the 2 patients died early after BNCT, 6 or 7 months after BNCT. Case 3 and case 8, I think they were very short survival time for patients with complete response. What happened to them after complete remission achievement?
This case These data are from Taipei Veterans General Hospital, so I'm not very realize the situation like this.
Okay, sorry, my topic, my question is not your topic. I know. Thank you.
Any question or comments? I have a question about you evaluate the equivalent dose using the fixed RBE or CBE. But in BNCT, the higher dose becomes that RBE is lower. So Argentine group suppose the ISO effect dose for the equivalent dose estimation. So do you have a plan to use the ISO effective dose in your evaluation? Okay, so later I will show you some data about the ISO effect dose. Any question or comment? Okay, thanks again, Lee-san. Thank you very much. So let me return to the Ran Sensei.
Okay. Next, we'll have the lunch time, and we have prepared a lunch box in the left of this conference room. And the next session will start at 1 o'clock. And please go to the simulation room in the first floor in the next building. And we will have 2 different schedules, and one is in the simulation room and talk about the patient positioning, and another group of the people can go to the reactor here, and Professor Pei will take everyone to the reactor and see this THOR facility. Okay, so let's have lunch now. talk at the simulation room. And please move slowly to the simulation room, and it is in the next building and in the first floor. And also, please come back to this conference room at 1:30. Thank you. The next session will start at 1:40. Session is nursing. I would like to invite the moderator, Professor Yi-Wei Chen.
Okay, good afternoon. In the afternoon, the first section is for our nursing care experience for BNCT. And our speaker is Professor Mu. And it's my great honor to introduce Professor Mu first. Professor Mu got his PhD degree from University in Minnesota, Twin Cities in the United States. And she became the distinguished professor and working in Department of Nursing, National Yangming University. And in 2020, Professor Mu also elected as a fellow of American Academy of Nursing. Professor Mu, she's an expert not only in research about the qualitative research, but she also can do a lot of quantitative research, just like the evidence-based medicine. And she also trained a lot of excellent and outstanding nursing care researchers on BNCT field. So today is our great honor to welcome Professor Mu to show us the experience of BNCT nursing care experience.
Thank you, Dr. Chen's introduction. It's my great honor to be here to share with you of our nursing program in taking of the patient receiving the BNCT. So the title of my topic is establishing a fraction adaptation program of patients receiving BNCT. BNCT is belong to the palliative therapy, and palliative therapy is given to help relieve the symptoms and reduce the suffering caused by the cancer or other life-threatening disease. And palliative therapy is help people to feel more comfortable. And earlier palliative care is very vital, and that is including the providing symptom management and optimize the quality of life. And each year, there are estimated 40 million people they are in need of palliative care, and 78% of them people live in low and middle income countries. Only about 14% of people who need palliative care currently receive it. and earlier delivery of palliative care become more important. And there's a study by Kathleen Searman, and they use a document analysis to identify the priority and opportunity for palliative and end-of-life care in United Kingdom. And 15 policy documents were analyzed, and the findings indicate there are 3 important things. The first one is providing integrated care and personalized care and the support for unpaid careers. And what's nurses' role in palliative care? And there's a qualitative meta-synthesis currently investigate the literature to identify the nurses' role in palliative care. And the findings indicate there are 4 things which are important in nursing roles. The first one is being available and doing the things which is based on the holistic framework of understanding people's needs, and being attentively present and dedicated, and standing in demanding situations. Our project is based on a family-centered palliative care model, and we call it Flushing Adaptation Program of BNCT. And the ontology of this program is based on the Michel hope theory, and which identify the being and coexistence is important for people to have a hope. And the goal of our project is Flushing, is based on the Searman positive psychology perspective. And the nursing intervention, the content of nursing intervention is coming from 2 research studies. The first one is we integrate the guidelines to understand the content of the intervention. And the second one is we based on the ethnographic method to understand the nature of whole-based intervention. This is the Marcel hope theory, and he is the philosophy of existentialism. He believes the knowledge is based on the life experience, and the self should be fully open to the existence, the experience of entering presence in the light of being. That's the way we have a hope. So being is the ontology of hope that underlies the experience of human existence. So Marcel's hope theory in palliative care provides us a framework which identifies the dynamic of hope. And all the intervention is to help people toward the being, and deeply personal and existential medical experience is important. And there's a professor mentioned, the hope is the radar to guide the ship in rough seas. So how to send a bad message to the people when they have a GBM or recurrence of brain tumor? The hope can enhance personal identity and overcome the negative emotion and thinking and the attitude. And hope is a creative process. So in the nursing intervention, we create a lot of interactions with patients and family to enhance their hope experience. So hope can be described as the memory of the future in reunion, remembrance, reconciliation with past, present, future, and the present yourself. The outcome of our intervention is Flushing. And Flushing is from the Seligman, Professor Martin Seligman, and he has a theory of positive psychology. And in his theory, he mentioned the Flushing is an optimal state of mental health, and also it's a well-being. And it comes from the extension and establishment of their broad and build of positive emotion. So he identified 5 concepts of Flushing, which including the positive emotion, engagement, meaning, positive relationship, and accomplishment. So in our study, there are research methods including two qualitative research methods. The first one, we're using scoping review. We integrate all the guidelines in related to palliative care of brain tumor to understand the content of palliative care of brain tumor. And the second research method, we use ethnography research method. We use participation, observation, and ethnography interviews with patients and family to understand the being of hope of patients receive BNCT and their families. So this is the first research method. We use a scoping review to identify the content of palliative care of patients with brain tumor. And totally, there are 15 guidelines, clinical guidelines were identified. And the finding of the integrated palliative care of the guideline is including the physical, psychological, social, spiritual, communication, and decision-making, and support for the family caregivers. The second research method, we use ethnography study. This study is from 2022, July to this month. It's very fresh. There are 11 patients and their families participate into this study, and one physician was interviewed. And totally, there are 30 times participation, observation, and interviews have been done. And the finding indicate there are 4 stages of their experience: pre-BNCT, during the BNCT treatment, and post the BNCT, they have a recovery well, and the last one is post BNCT, they have a recurrence, and they experience the anticipatory loss. The first one, pre-BNCT, there are 2 themes. The first one is a teamwork. Patient and family prepare the BNCT. We use the open and honest communication with patient and families of BNCT treatment and prognosis to enhance sense of mastery. And also, we have a shared decision-making methods toward patient and families' well-being and enhance patient and family self-care capacities and hope experience. And for the patients and families-centered care, because they have a GBM and a recurrent brain tumor, so they have experienced anticipatory loss already. So we were focusing on their understanding, familiar with their body, and live with illness. And we understand their uncertainty of waiting for the BNCT and enhance their family resiliency, strengthen their positive and open beliefs of family members in the face of illness. And during the BNCT treatment, the patient and the health professionals come to Tsinghua University. And there are 3 major themes we found from the study: professional and accurate treatment team, comfortable treatment environment, and patient and family feel at ease. And the nurses accompany and assist them engage into the treatment process. And they are very appreciate there are many angels caring of them. And you can see the photo here. The patient took ambulance from Venture General Hospital to the Tsinghua University in the morning. And before the treatment, we have a meeting to discuss the treatment plan and setting the position. I think this morning you have heard the whole process. And the professors and assistants help patients to set positions. It's very, you can feel they are very caring of the patient and family a lot. And also they illustrate the procedures for the families. And those are our nurses team. We are very appreciate having this opportunity to participate into the BNCT research team. And Dr. Chen always give a detailed illustration of what's going on of the treatment. And post BNCT treatment, the patient have experienced the recovery period. The patients gradually adjust and rebuild their self-identities. And family is also very important partner of the patients. We have found that a lot. And there are a group of people, they might go to the recurrence experience again. So they experience the anticipatory loss. During that time, patient and family, the goal of nursing care is comfort and dignity. And we help them to have a well-being in the end of life. We also have a care map because most of the patients from Venture General Hospital, but there are other patients from all around Taiwan. So besides face-to-face interview and consultation, we also use telephone to make connections. I would like to share 4 cases. The case 1, Mr. Jiang is 30 years old, GBM, have a brain tumor. The KPS is 80. And he received 2 BNCT. You can see these 2 pictures is before the BNCT, MRI, and the PET. And this is the post 1 month later and 3 months later. You can see the tumor almost disappear. And Mr. Jiang is a very resilient person. He faced the problems by himself. And after BNCT, the physical function is improved a lot. He participates in family activities a lot. And he engaged in the rehabilitation regularly. And he would like to share his stories on the Facebook. And he also get back to work. And he had mentioned he wants to be becoming a valuable person. Unfortunately, he died on the 2020. June 26, 8 months later. Ms. Huang is 28 years old. Diagnosis is GBM, and KPS is 70. She also received 2 BNCT treatment. And you can see from the picture is before the BNCT, the MRI, and the PET. And the post 1 month after BNCT, you can see the MRI and the 3 months. And the second BNCT post 2.5 months. And she enjoyed her work a lot. And she feels very proud of herself. And after the BNCT, she decorated herself with a wing and a makeup. She has a strong family system to support her. And she would like to be independent, to be a person, and she likes to be the way of being now. And the case is 3, Mrs. Lee, and she is 50 years old. Diagnosis typical meningioma, and KPS is 70. And she only received 1 BNCT. And you can see from the picture here, the before the BNCT, the MRI, and the PET. And those pictures is post 1 month, 4 months, 7 months, and 10 months. Until now, she is recovered very well. She loved her life a lot, and she never want to give up. She always worked very hard. And she integrated information and having her way of being and family cohesion and has a very strong support to her. And she took the rehabilitation regularly, and she planning to back to work. It's a very successful case. And cases 4, Mr. Zhang, he is 57 years old. The diagnosis is DIPG, and KPS is 70. And she received 2 BNCT. And you can see the photo here before the BNCT, the MRI, and PET. And post 1 month, the BNCT and the PET. And he is a very rich person. He exercised a lot before the illness. He aggressively serving the information, and he tried all the methods, the multiple treatment. Anything is good for him, he will do it. And he loved his life a lot. And he regularly take the rehabilitation, and he want to live a wonderful life even when he's sick. And he also want to be a volunteer for the BNCT team. Currently, we are still doing a project. We try to examine the effectiveness of this project, the program, the Flushing Adaptation Program of patient receive BNCT. And it's a one group of pre and test design. We estimate to enroll 30 patients into our study. And the data collection will including the pre-BNCT and 1 month after and 3 months later. And the outcome measure will be MRI and the symptom scale and the flushing scale and psychological well-being scale. And thank you very much.
Okay, thanks, Professor Mu's excellent speech. As we all know, without good nursing care, even we doctor provide a good treatment, the patient cannot have a very, very good recovery. So nursing care also play a very important role in the cancer treatment field. And Professor Mu care about the holistic care for our patients. And she not only care about the patient's physical condition, but also care about spiritual problems. So our patient can have very good nursing care after BNCT. So this is also the reason why we can treat so many patients and have very good quality of life. So is there any question audience want to ask Professor Mu? Okay. If no question, let's thank Professor Mu for her presentation.
Thank you.
Dr. Chen will explain the voting of the poster session.
Our next section is the poster section, and we have 10 presentations. And this time, all the presenter will have 3 to 5 minutes for the presentation. After the presentation, audience can ask the questions. So this time we have the 10 presenter. So we designed to have a poster vote. And later we will give everybody the sheet of vote. And we can choose the most 3 best presenter. And after the vote, maybe after calculation in the dinner banquet this evening, we will have the best presenter award. So please use this vote sheet to choose the best presenter you like. The most is 3, but you can also choose only 1, 2. If you choose for more than 3, it cannot be used. Okay. So our next section is a poster section. The first 3 presenters will be present online. So first 2, okay, will be present online.
The next session is poster session, and I would like to invite the moderator of the online presented. Poster is by Professor Nakamura Hiroyuki. Please, Professor Nakamura.
This is Hiroki Nakamura from Tokyo Tech, Japan. I am moderator, one of the moderator of this poster session. So first presenter is Dr. Tsubasa Watanabe from the Kyoto University. Can you hear me? Okay, could you start the presentation?
Expression. Furthermore, we use the TCGA database to see whether RAT1 expression in human tumors differs according to characteristics such as tumor origin and tumor histology. This figure summarizes the expression of RAT1 in various types of human cancer. The horizontal axis shows the strength of RAT1 expression, and the size of the circle represents the sample size of the database. As shown in the figure, melanoma is one of the top tumors that express RAT1. Head and neck squamous cell carcinoma is the next tumor that expresses RAT1. So we can see that the cancer types where BNCT has actually been performed so far are reasonable to use BPA with particularly high expression RAT1. For example, regarding the green circle tumors, we can visually see that squamous cell carcinoma such as esophageal, cervical, and lung squamous cell carcinoma tend to express RAT1 higher than other tumor histology. Next, we examine the association between RAT1 expression and cell proliferation markers in these human database. The upper left figure shows the association between RAT1 expression and Ki67 expression in all tumors from approximately 11,000 patients. Although there appears to be a general association, the p-value are not significantly different in this analysis. In the lower left panel, when only head and neck cancer are selected, the p-value was significantly different. Similarly, melanoma showed a significant difference with a p-value of less than 0.05. This slide shows Kaplan-Meier survival curves for patients stratified by RAT1 expression with high and low RAT1 expression. Looking at the association between RAT1 expression intensity and prognosis for all tumor types, we can clearly see a trend where high RAT1 expression, as shown in the red curve, has a worse prognosis, and low RAT1 expression, as shown in the blue line, has a better prognosis. In summary, we found a certain trend in RAT1 expression by tumor type and histology, which may serve as a guideline for selecting candidates for BPA-based BNCT indications in the future. Tumors with high RAT1 expression tended to have a poor prognosis. It was also suggested that the reason for this is that tumors with high RAT1 expression tend to proliferate more aggressively. Therefore, we may be able to insist that BNCT is particularly effective for tumors with poor prognosis. Yeah, that's all for my presentation. Thank you for your attention.
Thank you very much, Dr. Watanabe. Shall we have some questions from the audience? Is there any question, comment from audience? No? So if not, so thank you again for the Professor Watanabe for a very excellent presentation. Yes, let's move to the next speaker. It's okay. So next poster presentation is made by Dr. Takehisa Matsukawa from Juntendo University. And is this ready for to start the presentation?
Can you hear me? Can you hear me?
Dr. Matsukawa, can you hear me?
Yes.
Okay, just a moment. The screen is not ready. Okay.
Yeah.
Yes, we can see your face.
Yeah.
Yeah. Just a moment for we can see the your presentation slide.
Yes. I already share my screen for you.
Probably yes.
Okay.
Oh yeah.
Yes.
Okay. Okay. So please start your presentation.
Yeah. Thank you for introducing Professor Nakamura. I'd also like to express my gratitude to this meeting for providing presentation opportunity. Today, I will introduce ex vivo boron imaging method by using laser ablation ICP mass. At last year's this meeting, as Dr. Iwasaki presented, it was discovered that an overdose of BPA combined with intense neutrons led to decreased boron bone strength in mice NCT. Thus, it is important to understand the distribution of BPA-derived boron-10 in bone. As you know, examining the biodistribution of boron is essential. In ex vivo imaging, autoradiography with CR39 is utilized. This method is performed ex vivo on thin slices, tumor or normal organs of interest. However, it requires neutron resource, such as a nuclear reactor for autoradiography. In contrast, by combining laser and ICP mass technologies, we have developed a boron tissue imaging method that does not require a neutron resource. Laser ablation ICP mass uses a laser to vaporize a portion of the sample's thin section, which is then introduced into the ICP mass by reconstructing the signal intensity and the position where the sample was irradiated by the laser. Elementary imaging of the tissue is possible. For instance, this imaging is of brain tissue, which was obtained by altering the position of laser exposure and reconstructing the resulting ICP mass signal intensity transition. Moreover, since our target tissue is bone, we employed the Kawamoto method, specialized non-decalcified frozen section preparation technique to thinly slice the tissue of examination. Here is an example of our results. the distribution of boron in the bone itself can be imaged in the mouse treated with boron 10. However, this only represents signal intensity, not concentration. So in this case, we measured the bone in the foot on the opposite side conventional ICP mass to determine the concentration. This is an example of obtaining the conversion count and concentration. We calculate the correlation factor. So as a result, we found that the boron concentration in the bone increased with the BPA dose, and the boron concentration did not differ significantly from the boron concentration estimated by CR39. In conclusion, laser ablation ICP mass has demonstrated the potential for semi-quantitative imaging of boron 10 compounds without using a nuclear reactor. Although the resolution in this study about 25 micrometer, it is possible to obtain more detailed images by combining like this technique with an innovation method of laser irradiation. Thank you very much for your kind attention. Thank you.
Thank you very much, Dr. Matsukawa, for a very excellent presentation. So are there any comment and question from the audience? Yes. Tanaka Sensei, please.
Thank you for a nice presentation. My name is Hiroki Tanaka from Kyoto University. So my question is how many detection time using this method for the small sample?
Yeah, in this bone sample, we need about 3 hours.
For one sample.
Yes.
And if you increasing the detection, position resolution, such as 2 micrometers, something else, so you need more time.
Yeah,
you need
more time.
Okay. Thank you very much.
Other question? I have a question about how about the linearity, concentration dependent linearity of your mass spectral detection?
Yeah, maybe we use ICP mass, the linearity is good.
Oh,
but
really?
in this case, we imaging, so it is not accurate concentration. I think it's enough for imaging.
Yeah, I think the imaging is okay, but I think to determine the concentration is also very important.
Yes, of course.
Together with imaging, right?
Yeah.
So I'm just curious about ICP mass imaging is not accurate to the concentration dependency. How do you think?
Yeah. So it's important boron concentration in patient, but in this case we use animal experiment, so we can know the
distribution.
Tumor, yes, tumor
distribution of the compound in that. Yeah. Okay. Thank you. Other question or comment from the audience? If not, thank you very much, Dr. Matsukawa, for a very excellent presentation. Thank you.
Thank you very much.
Okay.
Thank you, Professor Nakamura. The further poster session will be held in downstairs, and there will be a coffee break after the poster session. So the next session after the poster session will start at 3:40. And during the coffee break, please complete the poster vote and put your poster vote on the desk of the moderator. So now please move to the downstairs for the further poster.
Okay. Thank you. Thank you for all the audience. And the first poster present on site is Mr. Nishiki Matsubayashi. He is a PhD student from Kyoto University. He also got an award research fellowship of young scientists. He will go to introduce the topic of study of optically stimulated luminescence dosimeter of BO ceramic in BNCT radiation field. So we invite you to speak.
Okay. Thank you very much. My name is Nishiki Matsubayashi from Kyoto University. I'm a PhD student and major in engineering. So I'd like to talk about this title. Introduction. BNC field, have neutrons with wide energy range and undesired high intensity gamma rays. So for quality assurance, that's QA of therapeutic effect and the safety of the treatments, the gamma ray dose rate was measured before each treatment. But now TLD, thermoluminescence dosimeter or BO powder, enclosed in quartz glass capsule, is currently has been used in this treatment, but it is currently out of production. So we need a new gamma ray dosimeter. So we select in this work optically stimulated luminescence dosimeter, OSLD. So in this work, I tried the calibration test at 60 cobalt gamma ray source and irradiation test at BNCT irradiation field. So this is a picture of the OSLD we used in this study. So and the calibration test and the irradiation test in BNCT field. So OSLD is in here and the neutron beam is irradiated in here. And so in the KR, Kyoto University, the cadmium shutter is here, can be changed, the thermal neutron flux with each aperture. The openness was 0 to 600 millimeter, and the result is here. This is a calibration test, the result. This line is gamma ray dose and the OSL signal count. A good linear, the OSLD has good linearity to the gamma ray dose, so we can convert the OSL signal to the gamma ray dose value, similar to TLD. And next, this is very important things. The neutron irradiation field test at the BNCT irradiation field. This line is cadmium shutter openness, and this is dose per thermal neutron flux as OSL signal. Then blue one is TLD signal, and red one is OSLD. So, and the TLD has thermal neutral sensitivity. So, this pastel blue one is pure gamma ray dose. So TLD, the count of TLD was overestimated by the thermal neutral sensitivity. So OSLD has a low thermal sensitivity. So this is very great. Sorry, in conclusion, the OSL signal was confirmed to have good linearity, and was able to measure the gamma ray dose equivalent to TLD. And you can remove the thermal neutron contribution from those value by using the correction factor. So, and it is confirmed that OSLD has low sensitivity, low thermal neutron sensitivity. It's very great. Sorry, thank you very much.
Okay, thank you, Mr. Kayabayashi. And any questions or comments from the audience? So I want to ask you a question. You said the thermal neutron sensitivity of the OSLD was less than that of TLD. Is it better? Is it good or bad for that? Which one is better? So OSL and TLD, which one is better to apply on the usage for this application? Yeah.
Thank you very much. With fading effect, which is so the OSL signal degrades for several times. So that's its merit to use OSLD.
Means it depends on the situation.
Okay. So I target the QA procedure in water phantom. So I tried to measure that in water phantom.
You also found another solution? Will you find another solution if the O0, you can just apply ceramic in BNCT directly, or we'll find another solution?
Yes, I think so, but okay, I'll try to do it. Okay, thank you.
Okay, thank you. So we'll close this presentation and move to another next presentation. Okay.
From the Kyoto University. So the next presentation is title. Presentation of the title is develop. Boron precursor 18 fluoride ion using synthesizer. So please.
Nice to meet you. I'm Yasukazu Kanai from Kansai BNCT Medical Center, Osaka Medical and Pharmaceutical University. So our purpose of this study is we think fluorine 18 FBPA is very important in BNCT, but now we produce FBPA by this method. This method is we use neon gas for target to produce fluorine 18. This method is very simple and reliable, but the final product of the FBPA, radioactivity of the FBPA is very small in amount. So, but by this synthesis method, we can produce only 1 or 2 patients for PET. So we try to improve this method to get a more higher radioactivity method. So our method is shown in this scheme. And we have already established, investigate and established this scheme in fundamental experiment. And in this study, we tried to the method we developed the method for automatic synthesizer. So we use this synthesizer, and materials and method is shown in here. As a result of our study, we succeeded to improve the synthesis method. We can get about more than 10 gigabecquerel of FBPA in the final product. So we succeed the synthesis FBPA from the fluoride ion using this machine, and we are ready for
use clinical use for clinical use. Thank you. Thank you for presentation. So, are there any comment or question?
I mean, but in one sentence.
It is very difficult because how many PET scanner or the protocol of the scan protocol depend on the.
So at the last step, this step require basic conditions. So do you see racemization of that positions? Do you have observed racemization of this position because it's basic conditions?
Racemization, no, yes.
Thank you for your presentation. I'm wondering how the amount of precursor you use, because in my experience, large amount of precursor can reach the.
Are there any question? Okay, thank you. So next speaker is Pei Fan Mu. I'm sorry. Can you? Later. I'm sorry. So the title of the presentation is based on the scoping review to establish a family-centered palliative care for patients with brain tumor receiving bone Newton capture therapy. Please start.
Good afternoon, everyone. I'm Huang Zhiyun. I'm honored to introduce my partner, Wei Zhen, and our professor is Professor Mu and Dr. Chen. And today, the subject of this presentation is to, based on the scoping review, to establish the family's care palliative care for patients who receive BNCT. Effective surgical and medical treatment for recovering the brain tumor may raise the longevity of patient. And BNCT was regarded as a successful treatment, palliative treatment for brain tumor. And we developed a family-centered care model to improve their quality of life. So the object of this study was based on the scoping review of the clinical guideline to develop a family-centered care model to patients with receiving BNCT care. And based on the finding of this scoping review, we have a 50 clinical guideline we include. So the family-centered palliative model include 5 domains, just as physical, psychological, social, and spiritual, and community and decision making, and supporting for the family caregiver. And then Ms. Wu will introduce the result to us. Thank you.
And based on the findings of scoping review, we developed a family-centered palliative care model, and it is effective in enhancing the quality of life of both patients and their families. And as shown in figure 2 to figure 4, an MRI image of 3 patients of a brain tumor recurrence indicates significant shrinkage of the tumors. And after they receiving BNCT, we provide those patients individualized nursing care and based on this care model. And we assess the specific needs of the patients and their families and providing a holistic care approach to address the impact, including coping with uncertainty, anxiety, and anticipatory loss, and so on. And this model reinforces the flourishing-based life values and provide an opportunity to integrate body, mind, spirituality of patient for symptom management and leading to improved quality of life. And this is our presentation. Thank you.
So are there any questions or comments?
Can you give me some example of how you actually provide care?
We use an internationality interviewing as an intervention to strengthen patients' resilience and flourishing, and also provide them support and care with clinical guidelines.
Thank you for your presentation, and I'm wondering any challenges or problems you have faced in your study. Thank you.
Our difficulty in this research
Difficulties or challenges?
Yes, just like some people have poor condition, and so we have the management to find their address the significant loss to improve their quality of life. And some people are just community difficult, so we will just enhance their family member to improve their quality or their family resilience.
Thank you.
Or 50, 300 and 500 patients. So the patient usually says the nursing in BNCT is very, very important. So the patient is appreciate for the nursing. So the patient often say the complaint to doctor, but the patient is usually is many things to the nurse. So please fighting to do the nursing in BNCT. And please this study is very important. Thank you.
So next presenter is next presenter is Tianlin Lang from the Taipei Veteran General Hospital. Yes, please. Yeah.
I will try my largest voice because this might be my first experience to present in the forest and in the wind. So I will try my best. And this is the early data of our patient treated by the BNCT for recurrent meningioma. And we have 4 cases in this study. So meningioma is one of the most diagnosed primary brain tumor in adult patients, and it is very difficult for us when it is in the recurrent status because most of these patients received previous irradiation, first diagnosis after the surgery, or their second treatment during the. So it will be very difficult for us to use the for meningiomas. So for these patients, we have selected patients that have a relatively high boron uptake. And it shows that the mean TN ratio of these 4 patients is 4.125, and the mean irradiation time is around 25. That we can treat these patients in such a fast time is because the high neutron power, the power of the reactor, and also the high blood boron concentration, like more than 32.23 ppm during the irradiation. And also, by the constraint of the mean brain receiving 3 gray equivalent and the maximum brain dose receiving 12 gray equivalent, those data of these patients is the mean tumor average dose is 29.4 gray equivalent, and the mean tumor is 15 gray equivalent. And the mean brain maximum dose is limited to 11 equivalent. So for this patient, 1 patient is diagnosed as the grade 1 meningioma, and 3 is by the grade 2 atypical meningioma. And the site is differentiated to the skull base or on the frontal of the brain. So the result of this patient, it showed that 2 stable disease and 1 complete response and 1 partial. So here I show the image of this patient, and patient 1 is a patient with the stable disease, and this image is taken before the BNCT, and this one is 3 months after, and this is the tumor 17 months after the BNCT. So we can see that the tumor is relatively very stable. And for the patient 3, it is a patient with complications. So after the patient was treated by BNCT, before the BNCT, we can see that there is a huge part of the perifocal edema, and after the BNCT was completed, we have an image 2 months after the BNCT, and it showed that the regression of the perifocal edema and also enhancement of the tumor. So a short presentation of this experience of meningioma, and we will conduct a larger study, like with recruiting more and have a longer follow-up time in the future. Thank you.
Much, Dr. Ray. So any question or comment from the audience?
So all patients underwent chemotherapy before BNCT.
Yes.
What kind of chemotherapy they had?
The chemotherapy is Dr. Lee? Okay. Yeah, I have discussed this question with her. I think it is by meningioma 用那个有一个会 regression 的。Oh, I will tell you about it later. Yeah. Because this. Okay, Dr. Lee. Sorry. Sorry. The chemotherapy regimen for the recurrent meningioma.
Actually, it's only hydroxyurea. Yeah.
And we use hydroxyurea for the control of the tumor. Thank you so much. I just forgot the name of the. Yeah, okay.
Okay.
And actually, this data is recently published in the article, and you can search for this title, and you can see the more detailed information of these patients. Thank you.
Okay. Yeah. Thank you very much. Yeah. So let's move to the next presentation. So next presenter is that one. Okay, Miss Dr. Su Chin Huang from the National Health Research Institute. Yeah, please start your presentation.
The topic is my research, chemotherapy mainly to radio sensitization of BNCT in the melanoma. The study evaluated whether etoposide can sensitize BNCT, increase cell uptake of BPA, or by inducing a population the G2N phase. the cell cycle. And this picture, we use 3 cancer cell lines. This is melanoma, and 2 is glioma. We treatment etoposide with BPA. Etoposide concentration from 0 to 4 micromolar, and boron uptake percentage, melanoma cell 2.5-fold, and glioma cell is 2-fold. By flow cytometrics, we use melanoma cell. Etoposide increase G2N phase population, and dose dependent. From 20% to 19%. Evaluate BNCT efficacy in cell base. We use melanoma cell, and treatment etoposide with BPA co-culture in 6 well play, and the 2 play is back to back, and the 2 play is back to back, bonding together. Reducing 300 seconds and 600 seconds. 1 and 2 play. Neutron close to neutron field. Neutron fluence is higher, and the 2 play is further to neutron beam. Neutron fluence is lower. Neutron radiation and THOR. After radiation, we culture the cell to see coloring formation. BPA around survival fraction is 5.7%, and etoposide with BPA survival fraction is 1.2%, and etoposide and melanoma cell boron uptake percentage 2.5-fold, and etoposide increase G2N phase population 2-fold. Radio sensitizer for BNCT by the combine etoposide with BPA around 5-fold change. Therefore, we just drug last called G2N phase array may have a great opportunity to sensitize BNCT. Thank you for your listening.
Thank you very much. Any question, comment from the audience? Yes, please.
I have one question. What is the mechanism, the reason why using BPA elevates the BPA uptake?
Yeah. I prepare a real bone uptake. It's glioma cell different, and it's low, it's higher boron uptake, and it's glioma cell is sensitive. Yeah. So we use treatment etoposide can increase BPA uptake.
How mechanism? Why etoposide increase BPA uptake? Why?
Why? Americans, we will plan next study. Okay, thank you.
Okay, other question? If not, okay, thank you very much, Dr. Fang, for the very good presentation. So maybe.
Okay, we will have last 3 poster presentation. All of them are from National Tsinghua University. The first one is Mr. Huang Yuxiang, he is also a PhD student and also work at THOR as a nuclear technician. He will present the topic about the liver cancer treatment recently at THOR. So please.
My topic today is mainly about salvage BNCT for metastatic liver tumor. From 2010 to this case, there have been 268 BNCT irradiation using Tsinghua open pool reactor with boron drug BBA. This is the first case of BNCT irradiation on liver tumor in Taiwan. This patient is a 54-year-old male. Multiple liver metastases were found after adjuvant radiation therapy with his primary tumor, adenoid cystic carcinoma. This is his posture during BNCT irradiation, and this is his CT image. We suppose the TN ratio of liver tumor is 1.5 in treatment planning. The boron concentration during irradiation is about 21 ppm using PPA. The endpoint of irradiation is the maximum dose of normal liver cell does not exceed 12 gray. This is the dose distribution after irradiation. This irradiation is mainly for partial tumor CTB1-2 when the normal liver cell, the maximum dose of normal liver cell does not exceed 12 gray. The maximum dose of CTB1-2 is about 27 gray. The average dose is about 9.8 gray. On February 10th this year, about 3 months after BNCT irradiation, the tumor dose of CTB1-2 it was a reduction about 90%, and there was no obviously side effect on nearby organ. So we think the liver tumor is a potential curable disease using BNCT. Thank you.
Thank you. Okay, any question or comments from the audience?
What is how is the CB factor for calculating the normal reversal dose? CB factor. 20 gray equivalent dose, weighted dose.
For normal liver, it's about 1.3. 1.3.
So
Okay.
same as
neural
neural
Yeah,
tissue.
right. Yeah. Any other questions?
How about the AST or AGT as a liver enzyme? Side effect. I know the side effect of the damage of the normal liver tissues.
After treatment, we use the blood sample to check the GOT, GPT, and something. No elevation. Yeah, safe. It's safe.
In our case, the level of the GOT and GBT about over the 200. Grade 2, grade 2.
This case is very special because it's metastatic. It's from head and neck cancer, not the primary hepatoma. So I think the situation is a little bit different.
What I think the situation is the same. That we irradiate the one port irradiation, the normal river. So I think the treatment volume is almost the same. I
But
think so.
maybe the treatment dose is a little
I
bit
think so,
lower.
Yes, I think so.
Thank you for your presentation. And I'm curious about that for the relatively low liver tumor TN ratio. Will it be the dose? I'm wondering that the dose for tumor cell will be not enough because of the relative low TN ratio. And you set upper limit of normal liver cell to 12 gray. So I'm curious about the dose for tumor cell will not be enough, or thank you.
All right. Okay, any other question or comments? If not, we thank you, Mr. Huang. So we move to another.
Thank you.
Okay, thank you. Thank you. We'll move to another topics. It's about the treatment plan system. So Ms. Wang Yilian is also from National Tsinghua University. Is a master student of Professor Rong Junshi's laboratory. This is his second year of master degree. So please introduce your topic, your presentation. Okay.
Okay. Hello, everyone. So our lab built a new treatment plan system for BNCT. The purpose of my study is to verify this treatment plan system and the source term of it. So by reviewing the previous study, I found that they measured in the phantom of filled with homogeneous water or PMMA phantom. And in these cases, they lake the profile between different materials. So I built a heterogeneous phantom and with Snyder head phantom as my reference. Additionally, I add 2 more structure into it. And beside of this, I also built 2 homogeneous phantom by PMMA. The verification workflow is as following here. First of the verification workflow of heterogeneous phantom. First is that the neutron activation measurement inside the phantom. And second is the analytical calculation done by MCMP. Then the last one is treatment plan system calculation. As for the homogeneous phantoms, they also will undergo a neutron activation measurement and MCMP calculation. And because this heterogeneous phantom is asymmetric, so I made 4 different cases by changing the direction of irradiation position and direction. And in each case, there will be 2 measurement position, region 1 at the center and region 2 at lower here. So this is the result of homogeneous phantom. And the green line is homogeneous cube phantom, and red line is homogeneous cylinder phantom. And the axis here is reaction rate and versus steps in phantom. And this is the heterogeneous phantom result from case 1 to case 4 in region 1 and region 2. For better understanding, I will judge the accuracy of calculation by CM ratio. And CM ratio is that calculation divided by measurement. So the closer to 1, the better. And this is the comparison of CM ratio of MCMP. And at source center is here. The calculation by homogeneous and heterogeneous phantom all have good accuracy. As for off center here, the heterogeneous phantom has least accuracy than the homogeneous result. And this is the comparison of CM ratio by treatment plan system calculation. And in source center here, case 1 has the worst accuracy because it has more heterogeneity medium, has more heterogeneous material in the measurement region. And as for off center here, the accuracy performance is similar to the MCMP one. So by the above result, the conclusion is that First, for MCMP calculation, a homogeneous phantom, cube, and cylinder has a similar result, and they all are accurate. And the second one is that in heterogeneous phantom, at source center, the calculation is accurate, but it is not accurate as source of center. And furthermore, treatment plan system is more easily to be affected by the heterogeneous phantom, heterogeneous material. And it is the end of my presentation. Thank you.
Thank you. Thank you. Any question or remarks from audience? So I have one question. And what is the computation time to do one simulation using your computer program?
Okay, in MCMP calculation, for one case to reach the error below 1%, is total 4.5 hours of calculation in each case. And for treatment plan system, to reach error less than 1%, the calculation time is about 20 hours.
And the same for homogeneous and heterogeneous calculation? The computation is the same?
So
Just different?
Homogeneous phantom has no treatment plan system calculation. So they all just do the MCMP calculation. So the calculation time is the same as the heterogeneous phantom.
Okay, all right. Okay, any other questions?
Why the more significant error in the off-center area in using the heterogeneous phantom?
The off-center means that the measurement position is at source of center, which is like this line compared to this source, and this line compared to the source here. So source of center is at this, and the source of center is here. So it's far from the center. It's about 7.5 centimeters.
Okay. Any others? Okay, thank you, Mrs. Wang. Okay, thank you. So we will move to the last presentation. And Ms. Zhang Ningqi, she is also a master student of Professor Rong Junxi, and she will introduce about something related to the THR-BNCT treatment rooms, the gamma dose of during the treatment presentation. Okay.
Okay, ladies and gentlemen, hello. And so in general, the medical workers of THR-BNCT will need to wait for the reactor to completely shut down and the detected dose inside the treatment room to reduce less than 15 microsievert per hour, so the workers can enter the treatment room and move the patient to the rest area. And the whole waiting time is about 1 to 2 minutes. But if an emergency occurs to the patient, in order to rescue the patient as soon as possible, the workers will often enter the treatment room immediately for the first when the beam is not completely off. So the purpose of this study is to investigate those workers will rush into the THR-BNCT treatment room. So the dose contribution needs to be considered in the evaluation in this study, include residual beam and activation. So to calculate the residual beam dose, when use the MCMP simulation with THR-Y09 source files and the Neutron online monitor systems information to calculate the residual beam dose contribution. and to calculate the contribution from activation. And we use MCMP to simulate, and the analytical flux formula to initially calculate the importance of each materials in the treatment room, like this picture. So then we can change the calculation method, like long-term periodic irradiation and the nucleus distribution to improve the accuracy of the evaluation. So based on the current results, and we can say that the medical workers should be aware of the dose from residual being, especially the neutron. And after the reactor is completely shut down, the main dose contribution comes from a patient when the medical workers are very close to the surface of the treatment site. Yep. So this is my whole presentation. Thank you.
Thank you. So any question or comments? I have one question. In your opinions, for how long the people can go in to under normal case?
In my opinion, I think the better time is after 3 minutes of the beam is turning off. So the many contribution will come from the comes from the activation, and this is now very high compared to the residual beam.
So what is the dosage that the workers will receive the dosage after 3 minutes? They go into in your model. Yeah.
It's still ongoing research, so you can say that there is something nucleus that we don't consider in, so it's still in progress.
Okay.
Yeah.
Okay.
So I can tell you the best
you can tell me later. Okay. Yep. Yeah. Okay. Thank you. So any other questions? Well, if no other question, we will close the presentation, poster presentation now. Thank you.
Start at 3:40, and it will be a coffee break right now. And please remember to put your vote in the desk of the moderator. Thank you.
Do not sign your name on the vote. Yeah.
Please do not sign. Don't sign on the vote.
The next session will start at 3:40, and we prepare a lot of delicious snacks in the left of this presentation room. Please go to the left of the presentation room to take your omochi. The next session will be drug biology. This is the last session of this afternoon, and it is also one of the most frequently discussed issues in the field of BNCT. So now I would like to invite Professor Po Shen Pan and Professor Jiankun Chen to be our moderator.
So thank you for coming back for this section. I'm Jiankun Chen from National Health Research Institute, Taiwan. Professor Pan and I will host this section. The first speaker, Professor Yanagi, comes from the visiting researcher of Institute of Engineering Innovation of University of Tokyo. We know that Yanagi Sensei devoted himself very long term in drug delivery system. So let's welcome for his speech.
Thank you very much. I just connect the slide. Can you show my slide? Can you show?
Yes, Sensei, we can see the slide now.
You can show?
Yes, no problem now.
Okay, I start. Okay, thank you very much. Can you hear my talk? Okay?
Yes, very clearly.
Okay, thank you very much. Good afternoon, everybody. I appreciate to Professor Yue Chen, Professor Ono, and Professor Kirihata, and every organized person to have a chance to talk my research work today. I'd like to talk about the previous work and the ongoing works for BNCT applying to the hepatocellular carcinoma. I have no COI with regard to our presentation. The mortality rate of HCC is still high. Recently, non-alcoholic fatty liver disease, NAFLD, and non-alcoholic steatohepatitis, NASH, attractive attention as the underlying disease of HCC. We build a treatment policy based on the Barcelona clinical liver cancer criteria. In the early stage, we will choose the ablation, resection, and transplantation. In the intermediate stage, we will choose transarterial chemoembolization. In advanced stage, we will choose sorafenib et al. Molecular targeting therapy. Most HCC cases are considered to be incurable, and there are only few treatment options for prolonging survival. A mixture of anti-cancer agent and ripaudol has been used widely for treatment of HCC with arterial injection chemotherapy. Insert catheter from femoral artery and put forward to hepatic artery. After taking hepatic arteriogram, anti-cancer agents are administered. The anti-cancer agent becomes separated easily from ripaudol and do not remain in the tumor, so its utility is limited. We prepared water in oil in water, WOW emulsion for arterial injection therapy for HCC. The anti-cancer agents are completely entrapped in the emulsion. We consider neutron capture therapy as one of the multidisciplinary treatment for HCC. We had developed the BSH entrapped WOW emulsion. The table shows that beaten concentration in hepatic tumors and normal liver tissues of VX2 hepatic tumor bearing rabbit model after intra-arterial injection of BSH WOW emulsion or a BSH ripaudol mix. You can see the high concentration boron, more than 25 ppm, was accumulated in the tumor tissue by using WOW emulsion after 7 days intra-arterial injections. And also, you can see the tumor growth suppression by BNCT with intra-arterial boron delivery using BSH entrapped WOW emulsion. We had performed the pilot clinical study of BNCT to recurrent HCC using intra-arterial injection of BSH entrapped WW emersion. I appreciated to Professor Ono and all of KUR members for safety performance of this study. Tumor growth was suppressed by BNCT. The tumor was stable in size until 3 months after BNCT in first clinical study case. We think that WW emulsion is one of the possibility for DDS to hepatocellular carcinoma for the first targeting delivery to tumor by EPR effect. But it is necessary to develop the second targeting delivery to cancer cells with increase of mechanism by endocytosis and fusion. The WW emulsion was prepared using the double membrane emulsification technique involving a controlled poor glass membrane. The technique needs approximately 6 hours or more, so we aimed to develop the medical device which makes it simpler and easier to produce an equivalent WW emulsion compared to conventional making instrument. This figure shows a model of the mixing device with 3-way coke for preparing WW emulsion by manual pumping. In this study, we developed the cylinder-shaped medical device which we attached to SPG millipore filter. BSH was dissolved in the glucose solution, which was filtered through first SPG controlled poor glass, and then emulsified in lipiodol containing surfactant to form the water in oil WO emulsion. The WO emulsion was then emulsified again and aqueous phase containing saline solution and surfactant through a second SPG controlled poor glass membrane using this medical device. We were able to produce the WW emulsion of the same size even after the changing the hand. We can keep the volunteer concentration in the same concentration 2 days after preparation of WW emulsion. We had performed a single-dose toxicity study by intra-arterial injection of BSH-WW in rabbit. As a result, there were no test article-related change in any of the BSH administration group in surviving animals. Deposit of lipid was seen in the tumor tissue by oil red staining. Deposit of WW emulsion was seen in the feeding vessel of tumors. Accumulation of droplet WW was seen in the cytoplasm of VX2 cancer cells. Electron microscopic figure of WW emulsion was shown the accumulation of the fat drop of WW emulsion in the tumor site and in the cytoplasm of VX2 cancer cells. I repeat that I think that WW emulsion can be used for DDS to HCC for the first targeting delivery to tumor site by EPR effect. I hope to banish the HCC tumors by BNCT. So it is necessary to develop the second targeting delivery of the boron or gadolinium atoms into the cancer cells. We hope entrap the second targeting delivery systems into the WW emulsions. I show the ongoing experiment. Firstly, I show the liposome collaborating with Professor Nakamura, Tokyo Institute of Technology. We propose the application of the BSH entrapped transferrin conjugated polyethylene glycol steroid boron lipid coating liposome. BSH transferring PEG-DSBL liposome as a delivery carrier of boron compound for intra-arterial injection in BNCT. When BSH transferring PEG-DSBL were administered intra-arterially at a dose of 6.4 milligram boron per kilogram, the B10 concentration in tumor to around 25 ppm at 70 hours after the intrahepatic arterial injection of this liposome into the VX2 rabbit hepatic model. The concentration of boron in normal hepatic tissue were 10 to 15 ppm 72 hours after the intrahepatic arterial injection. Tumor normal tissue ratio was 2.0 at 48 hours after liposomal injection. We observed the selective uptake of the B10 by cancer tissues compared with that by normal hepatocytes in the VX2 rabbit hepatic cancer model. After BNCT, the suppression of tumor growth was noted with the thermal neutron irradiation after the intra-arterial injection of BSH transferring PEG-DSBL. With a smaller tumor size in the group treated with these liposomes than in the untreated group and the group treated only with the thermal neutron irradiation. We also shown the apoptotic body by electron microscopic findings. And the next is next experiment presentation of the lipoplex entrapped WWML region in near future. DNA cationic ribosome complex have considered as a potential non-viral vector for gene therapy. Professor Maruyama, Teikyo University, have prepared new type plasmid DNA cationic liposomes, so-called quaternary complex, QPlex. QPlex was prepared by sequentially mixing ionic saturated human transferrin with cationic ribosomes and condensed complex of DNA with protamine prior to the formation of the ribosome plasmid complexes. We had applied polyoxo molybdate mixed with QPlex. Intratumor injection of polyoxo molybdate with QPlex could increase the retention of the compound in the tumor. So we applied these lipoplex mixed with boron or gadolinium compound. You can see the QPlex. This schema is a QPlex. QPlex were prepared by transferring a cationic riposome and the DNA and the protamine. When we use the QPlex, the percentage transfected cell with exposed to for 4 hours with QPlex was 60% as compared to the 2 to 3% with lipoplex in XGR staining assay. So we prepared the gadolinium polyplex or boron polyplex. The boron or gadolinium compound mixed with hyaluronic acid instead of the transferrin and the protamine, then mixed with the cationic riposome or polyethylene. We also prepared the subcutaneous tumor model using the human pancreas cancer SPC1. Tumor growth suppression was recognized by gadolinium NCT using gadoplex to the SPC1 pancreas cancer tumor. 2 hours after intratumor injection in comparison with the other control groups. The cancer cell showed the hyalinization and degeneration was seen in the gadolinium solution and the gadoplex treated group after NCT. The apoptotic change were dominant in the GAD-NCT treated group with GAD-plex. We recognize the augmentation of tumor growth suppression on gadolinium neutron capture therapy by electroporation. We also prepare the boron polyplex mixed with a BSH. Tumor growth suppression was recognized by intratumor injection of the boroplex, boron polyethylene, and performed the electroporation. And then we performed the thermal neutron irradiation on ASPC1 model. We also show the new type of the boron compound for entrapment into the WW emulsion in near future. Emeritus Professor Yamase, Tokyo Institute of Technology, had developed the new polyoxoboronate as one of the applications of the polyoxometalates. I call this compound B32. This compound composed with 32 boron atoms in one molecule. We evaluated the activity of cancer cell suppression by colony formation assay after thermal neutron irradiation in vitro. And also, we evaluated the tumor growth suppression by thermal neutron irradiation using the B32 polyplex intratumoral injection. We also performed the electroporation, and also we performing the bubble liposome injected and ultrasound stimulation. Cancer cell cytotoxicity was shown at more than 30 ppm of boron atoms in B32 solutions on thermal neutron irradiation. There were no acute toxicities, for example, weight loss, obstructive jaundice, edema, in the B32 administrated group up to 2,000 micrograms. In the examination of the BNCT using B32 polyplex to the ASPC1 pancreas cancer tumor, tumor growth suppression was seen in compare with non-irradiation groups. BNCT performed 2 hours after intratumoral injection of B32 polyplex and electroporation, and then we performed the thermal neutron irradiation in vivo. And also, this is just to finish the experiment on this March, 8th March. In the examination of the BNCT using the B32 polyplex to the ASPC1 cancer model, tumor growth suppression were also seen in compare with non-irradiation groups. BNCT performed 2 hours after intratumoral injection of the B32 polyplex and mixing injection with bubble liposome, and then ultrasound stimulation were performed, and then performed the thermal neutron irradiation. Okay, conclusion. We hope to apply the NCT for recurrent multiple HCC as a multidisciplinary treatment. In order to increase cancer cytotoxicity by NCT, it is necessary to accumulate the boron or gadolinium atoms into the cancer cells. We hope to construct the targeting system with the first delivery and second delivery intracellular cytoplasma, especially nucleus. We firstly propose the application of the BSH entrap the transferrin PEG DSBL liposome as a delivery carrier of the boron compound. Secondly, we apply the external stimulation of the augment the B10 and gadolinium delivery to cytoplasma by electroporation or ultrasound bubble liposome systems. We will apply Jesus Boloplex and Gadoplex systems entrap into the WW emulsion in the next stage. Thirdly, we check the neutron capture reaction of the new boron compound, polyoxyboronate B32, using gene delivery complex system. We hope to apply this new DDS to the neutron capture therapy for the recurrent multiple HCC in near future. Thank you for your attention.
Thank you. Then we welcome questions from audience. Any question? We can have one short question. Yanagiye Sensei, I have one question.
Yes.
Can you comment or educate us how about the drug loading content for the drug delivery system is enough for a practical clinical therapy? How about the drug loading content would be necessary? How high that is?
Sorry, please repeat again.
We know that the drug loading content for drug delivery system is very important. How about the percentage of the drug you demonstrate in your study?
Delivery loading system. Percentage,
Percentage. Maybe 10 or 15% is enough for.
Yeah. In liposome?
Yes.
In liposome, I think the 10 to 15% entrap in the liposome, I think.
Okay, thank you very much. So we are glad to have a chance to see you. We wish to have a chance to see you in person next time. Thank you very much.
Thank you very much.
Let's move on to the next talk. This talk is delivered by Ms.请於正. Ms. Zhang comes from Professor Jin-Yi Wu's lab in Yangming Jiao Tong University. Ms. Zhang is now in her first year of PhD program. Let's welcome her speech now.
Good afternoon, everyone. My name is请於正. I am from National Yangming Jiao Tong University. Thank you all for being here. I am very glad to have this opportunity to share my study with you. And my topic is the therapeutic efficacy of using BPA-mediated boron neutral capture therapy against colorectal peritoneal metastasis. In opening, I would like to introduce the colorectal cancer. It is the leading cause of the deaths in both men and women worldwide, and the incidence of the colorectal cancer is increased year by year. And in Taiwan, these statistics show the mortality rate of the top 10 cancer in 2019. The colorectal cancer is number 3. And in initial stage of the colorectal cancer, the patient can be treated with the surgery combined with the chemotherapy and the radiotherapy. And it will have the better ideal prognosis. But in some cases, especially when the patient with the advanced tumor, their tumor will diffuse to the peritoneum and become the diffuse tumor. So this patient cannot be treated with the traditional treatment. So developing a new effective treatment is urgently needed. Boron neutral capture therapy, BNCT, may be a candidate. It is a binary treatment strategy. When we deliver the boron-10 drug to the cancer cell and irradiate the thermal neutral, the boron 10 will become alpha particle and lithium. And these two particles has a high LET but low range, so it can destroy the tumor cell without hurt the normal tissue. In clinical, the most widely used drug is boron phenylalanine, BPA. It is an analog of the amino acid phenylalanine. So it can be recognized by the LET1. And LET1 is overexpressed on many cancer cells. So BPA can enter into the cancer cell by LET1. But how can we know the BPA is distribution in our body? Maybe an image guide can save patients unnecessary cost and time. And BPA and FBPA, their structure are very similar. Only difference is FBPA has fluorescing on this location. And there are some reference indicate that these two drugs has almost equivalent. Their biodistribution in our body is almost equivalent. So we can use FBPA PET imaging to select the patient is suitable or not for a BNCT. And here are some examples. First, this is a GBM tumor, GBM patient. After receive the FBPA PET imaging, its TN ratio is 4.7. And the clinical standard value is 2.5. So if the TN ratio bigger than 2.5, these patients are suitable for BNCT. And another patient is TN ratio is only 1.9. So these patients are not suitable for BNCT. So in this study, we aim to evaluate the peritoneal colorectal cancer for the BNCT. So first, we need to establish the tumor model, and then we need to choose the route of the administration, IV or IP, and do a series of the experiments to make sure the tumor cell will uptake the BPA. And then we do the FBPA PET imaging. We screen our model as the clinical procedure. If the TN ratio bigger than 2.5, that means that our tumor model are suitable for BNCT. So we can perform the neutron irradiation experiment. And also we want to combine with the HIPEC, which is a hyperthermic intraperitoneal chemotherapy. When we hitting the drug BPA about 40 degrees Celsius, it can increase the peritoneal permeability and then increase the tumor uptake. And maybe it has a better treatment result. But when we start our experiment, we found that we have some problem to getting the FBPA. In Taiwan, we synthesize the FBPA by F2 for reaction, but this method has some limitation. So the yield and the specific activity are very low. And more unfortunately, we found that last year the hospital are not offer the FBPA. So we need to synthesize the FBPA by ourselves. And here is our synthesis stand scheme. We can synthesize the NCA FBPA by 5 steps. We can synthesize by fluorination, iodination, boration, alkylation, and hydrolysis. And first, we use this precursor. We dissolve the precursor in DMSO, and then react at 140 degrees Celsius for 20 minutes. And the labeling efficiency is about 75%. And we can get the compound 2. And we trap the compound 2 on C18 set pack, and then perform the reduction reaction by using the sodium boron hydride. And after 3 minutes, we do the aldination. And we heat the set pack to about 45 degrees Celsius by hair dryer. And after the aldination, we use the toluene to elute the compound 3. And then we can do the alkylation reaction. And this reaction, we need to add the phase transfer catalyst in the alkali environment. And after 5 minutes, we perform the borilation in DMF4 react at 140 degrees Celsius for 30 minutes. And the last step is the hydrolysis. We use the hydriodic acid, react at 180 degrees Celsius for 15 minutes. And our core products are purified by HPLC. And in the HPLC radio signal, we can see our NCA FBPA retention time is 10.5 minutes. And the CA FBPA from the hospital is about 11 minutes. And here is the summary of our synthesis. We use the precursor 15 milligram, and the labeling efficiency is 17%. And the non-decay corrected yield is 6%. The totally prepared time is 2 hours. After we get the NCA FBPA, we do the biological experiment to compare NCA and CA FBPA. First, we do the cellular uptake experiment. We use the 2 cell line, CT26 and SARS. CT26 is a colorectal cancer, and SARS is head and neck cancer. And we can see in the both groups, CA and NCA, their cellular uptake are similar. And also we do the inhibition experiment. Because the BPA can enter into a cell by LET1, so we choose the BCH as the inhibitor. So by adding the inhibitor BCH, we can see that both groups, the CA and NCA FBPA, their cellular uptake are significantly decreased. So this result indicates that both of them go the LET1 pathway. And also we do the micro-PET imaging. And this imaging is CT26 and the SARS. Tumor-bearing mice at 1 hour after IV injection about 20 microcurie FBPA. And both NCA and CA FBPA are accumulated in pancreas, kidney, and the tumor. And also we do the biodistribution. The results show that both groups, their distribution are similar, and there are not significantly different between these two groups. So after we select our drug source, so we can begin our experiment. We need to choose the route of the administration, IV or IP. In clinical, BNCT usually use the IV injection, but as mentioned earlier, we want to combine with the high pack, so we want to know the IP injection is feasible. So we do the biodistribution to compare this IV 1 hour and IP 3 hours. The results show that except for pancreas and the kidney, the tumor uptake is higher than the normal tissue. And there are some references indicate that mice pancreas overexpress the LET1, so BPA may accumulate in mice pancreas. And the kidney is the metabolic organ, but it belongs to the posterior abdominal organ, so we don't too worry about the side effect of these two parts. And the results show that the tumor uptake IV 1 hour and IP 3 hours is 9.4 and 10.7. The TN ratio is 5.8 and 8.9. So this result indicate that IP injection is feasible. So we also do the micro PET imaging. By IVIS, we only can see the tumor is grew or not. But if we want to transfer to the clinical, maybe MRI is a better choice. So we can see in the T2 waiting MRI imaging, the peritoneal CT26 mice, their intensity is not as smooth as the normal mice, and the tumor attached to the intestine. And this is a PET imaging. It's a peritoneal CT26 mice at 3 hours after IP injection for about 300 microcurie FBPA. And we can see the FBPA accumulate in the tumor site. And also we sacrifice the mice and do the biodistribution, and we get a similar result. And we can see the tumor uptake is about 8%, and TN ratio is about 4.4. So these results indicate our tumor model is suitable for BNCT. So we do the neutral irradiation experiment. We give the CT26 mice 25 milligram BPA fructose by IP injection. After 3 hours, fix them on the mold and irradiate 30 minutes neutral beam. And the result showed by the survival curve. The blue line is the control group. We can see the mice all died before 19 days. And the green line is give them only neutron. The mice died before 20 days. And these two groups, the mice die because of too many tumor. And by IVIS, we can see that after BNCT, the tumor disappeared, but it recurrence at about 40 days. But compared with the control group, we prolong their lifespan about 20 days. So actually, the specific mechanism of the cell death after BNCT we are not known. But we found that also we can establish the peritoneal colorectal cancer in the new mice. And we give them the same condition to treat them. We found that the treatment result is not as well as the biopsy mice. So maybe the immunity play an important role in BNCT. So evaluation of early and late marker of cellular response after BNCT is necessary. Summary, in this study, we demonstrate that the potential of using BPA-mediated BNCT to treat the mice with colorectal peritoneal metastasis, and maybe combined with the chemotherapy, immunotherapy, or HIPEC, can improve the survival or life quality to the patient with the advanced colorectal cancer. Thank you for your listening.
Thank you very much for your very nice presentation. Now welcome the question from audience. Sensei first.
Yeah, thank you very much. Very nice talk. I asked you about your FBPA is a racemic compound. Racemic. Not so L. Not so L. Plus minus. Your synthetic method, you can get also that's a racemic compound. Yeah, maybe also LAT1 is selectivity to L-home amino acid. Professor Kodere, in the old ages, and he has published in the generally in cancer cell, LBPA is selectively so about 7 or 8 times to incorporate it selectively. And that your FBPA is racemic compound, I think so. Yeah, if you this data synthetic method, so immuno It's a allele iodide conjugate. That's so no. Did you use so chiral agent? Yes, it's a racemic. I think that's so good for. I think so.
Yeah, I have a same question because you said PTC. PTC, the phase transfer catalyst, right?
Yes, phase
So
transfer.
what kind of catalyst did you use?
What kind?
I think that catalyst is very important to produce the chiral compound, right?
Yes, it can select the chiral, and we choose.
So I'm asking what kind of the phase transfer catalyst did you use for this?
Kamura Sensei asks you what kind of the catalyst, 催化剂, in your study, because the catalyst is very important for the reaction.
Right.
That? Maybe Professor Jingyi Wu here.
Probably the Maruyama catalyst. I think Maruyama catalyst.
Jingyi is here.
Okay, thank you very much. About the racemic, the issue, maybe you can go to the slide. Maybe you show the chiral analysis, right? You have a slide to show the chiral analysis, L-type. No, not this one. Chiral column analysis result. No? Okay. Due to the region-specific catalyst we used, so we can get the variegating only in the form of L-type. So even there is a chiral center, but we don't see any R-form variegating BPA. But due to, how about the PTC? What's the specific name? I can't memorize it. But we published the detail on the NMB. So maybe
okay. But I think that you should show the chiral, enantiomeric gases, that it should be, because the L form is very important for, as Hiriata Sensei told you. So maybe you should show the, if you use a chiral catalyst, so you better to show the enantiomer excess ratio in your slide. Okay.
Thank you.
Yeah. Thank you.
Thank you very much. We're really happy to have our participants discuss later, maybe in the closing remark or later dinner time. So, because the time limit, we have to move to another talk. Then I hand over the time to Professor Pan.
So our next speaker is Professor Takeshi Nagasaki from Osaka Metropolitan University, formerly known as Osaka Prefecture University. So his talk today will be mentioned about the bispecific antibody system. So please.
Thank you, Chairman, Professor Pan. I'm Takeshi Nagasaki from Osaka Metropolitan University. It's my great pleasure to be here. First of all, I would like to thank Professor Ono, Professor Chen, and all of the organizing committee for giving me such a nice opportunity to talk about our recent research. In this presentation, I would like to talk about BNCT boron delivery systems using novel bispecific antibody. As you know, many studies on BNCT boron delivery systems using antibodies have been reported so far. As far as I know, the pioneer are Professor Yanagie and Professor Bass, who published this paper in 1994. Since then, many studies have been published. One example is shown here. Furthermore, boron delivery system using immunoliposome have been reported by Professor Yanagie in 1997 and Professor Bass in 2007. On the other hand, also not numerous boron delivery system using bispecific antibody have also been reported. For example, Professor Hawthorne and Professor Bath separately reported the IgZ type bispecific antibody, which has binding ability toward tumor cell-associated antigen and polyhedral boron anion, such as BSH. However, the authors pointed out two problems. The first is that in order to achieve the required amount of boron concentration in tumor tissue, high molecular weight boron drug containing a large amount of boron atoms in one molecule is required instead of low molecular weight boron drug. Second, IgZ type bispecific antibody consists of two kinds of heavy chain and two kinds of light chain. There are 10 combinations. So the ideal yield of desired bispecific antibody is only 12.5%. And a difficult purification process is required. Therefore, it seems that the practical use has not yet been achieved. To overcome this problem, the double-headed bispecific antibody was designed here as shown this slide. A single heavy chain and single light chain afford only one IgZ type antibody. Therefore, llama-derived binding region, VHH, which has binding ability with only one heavy chain, is conjugated to terminal of the heavy chain. In this double-headed bispecific antibody, the variable region of IgZ can bind antigen A, and the opposite VHH can bind another antigen B. In this slide shows the format of the bispecific antibody and the structure of boron drug used in this work. Here, BSH HER2 bispecific antibody and BSH bearing BSA are abbreviated as our BSAT antibody and BEB, respectively. Also, I'll omit detail about how to prepare BSA2 antibody. We obtained the genetic information of the variable region of the rabbit IgZ antibody that bind to BSH from lymphocytes of rabbit immunized with BSH modified KLH. Then genetically engineered heavy and light chain expression vectors for BSA2 antibody were constructed. The desired BSA2 antibody was obtained by co-transfection of these two expression vectors in animal cells and purifying the circulated antibody. In addition, BSH modified BSA, BEB was prepared with bifunctional cross-linking agents, EMCS, that has maleimide and N-hydroxymide ester. 20 BSH residues are conjugated with BSA per molecule. Let's move to functional evaluation of BSA2 antibody. We first evaluated the binding ability of BSA2 antibody toward BSH by ELISA, as shown here. As indicated in blue bars, when BSH is immobilized, the intensity increased in a dose dependently. It indicated that BSA2 can bind to BSH. This slide shows the binding ability to HER2 evaluated by flow cytometer. The peak shift in HER2 positive SKOV3 cells and no shift in HER2 negative MDA MB231 cells revealed that BSA2 has our ability to bind to HER2. This slide shows a simultaneous binding ability of BSA2 toward BSH and HER2. BEB was immobilized, and after addition of BSA2 and biogenerated HER2, and last HRP-labeled streptavidin were applied to sandwich ELISA. As indicated by black bars here, when BSH is immobilized, the intensity increased in dose dependently. It shows that BSA2 can bind to BSH and HER2 simultaneously. Next slide shows the translocation behavior of BSA2 into cells. It was evaluated using a flow cytometer. BSA2 is modified with pH-rot fluorophore to emit fluorescence in the acidic pH conditions, such as endosome and lysosome. The peak shifted with time in HER2 positive cells, whereas no peak shift was observed in HER2 negative cells. It suggested that BSA2 is internalized to cells by endocytosis after binding to HER2. A confocal microscopic observation was also carried out to confirm intracellular translocation by endocytosis. This slide shows the results of confocal microscopy. The fluorescence intensity of the cytoplasm increased with the passage of time. And it grows in the form of dots. Magnifying makes it clear. These results indicate that cell uptakes of BSAR2 antibody is achieved by endocytosis. Next slide shows the pharmacokinetics of BSAR2 antibody in tumor-bearing mice. Human ovarian cancer cells were implanted subcutaneously in the right thigh of immunodeficiency mice. Tumor formation was confirmed 60 days after transplantation, and near-infrared fluorescence-labeled BSAR2 was administered through the tail vein. Fluorescence-labeled BSAR2 was monitored with in vivo imaging system. After 6 hours of administration, accumulation in tumor tissue indicated yellow circle was confirmed. This slide shows the pharmacokinetics of BEB. Also, BSAR2 accumulation in tumor tissue was confirmed, but BEB was not. One of the reasons is a low affinity of BSAR2 antibody to BSH. Dissociation constant is estimated as 400 nanomolar. Another reason is unsuitable administration timing. Therefore, we gave up on sequential administration of BSAR2 and BEB to tumor-bearing mice and decided to administrate BSAR2, BEB as a complex. Pre-organization of BSAR2 antibody with BEB was estimated with the change of hydrodynamic diameters by using dynamic light scattering measurement as shown here. Compared with BEB or BSAR2 alone, the size of complex increased to 31 nanometer. BNCT in tumor-bearing mice was performed using the method shown in this slide. 24 hours before irradiation, 200 micrometer of BEB alone or BSAR2 BEB complex solution was injected into the tail vein of SKOV3 tumor-bearing mice. The boron concentration at this time, this solution was 280 boron ppm. As a control, BPA fructose complex was subcutaneously administered 1 hour before irradiation. Irradiation of thermal and epithermal neutron was performed at KUR under the condition of 1 megawatt and 60 minutes. This slide shows a change in body weight and tumor size after BNCT. The graph on the left side shows the weight change after BNCT. There was no significant change in body weight under any conditions. The compounds and irradiation used here does not seem to cause a serious acute toxicity. Irradiation and administration of BSAR2 BEB complex, as shown by this green line, inhibit increase of tumor volume compared to other groups. Especially BEB B32BEB complex suppresses the tumor to growth more than BEB alone with irradiation, as shown by sky blue line here. Let me summarize my presentation. Double-headed bispecific antibody against BSH and HER2 shows first simultaneous binding ability to BSH and HER2. Second, internalization ability into the HER2 positive cells by endocytosis, and accumulation ability in the mouse tumor tissues. And also shows expression ability by BNCT using complex with BEB. Therefore, from these results, B32 is promising as a BNCT boron delivery tool for HER2 expressing cancers. Thank you for your kind attention.
Thank you, Professor Nagasaki, for your wonderful presentation. We are going to accept one question. Is there any questions? I have few, but only I have one chance. So I'm going to ask one of my really interested questions. So as you mentioned on page 16, the mouse is radiated for 60 minutes. During that time, is the mouse under anesthetic, or how do you keep them not moving? For the 60 minutes, all this mouse was under anesthetic?
Not yet.
No? Okay. Okay. I have some other question. Maybe later I can. Okay. Let's thank Professor Nagasaki for his wonderful presentation. Okay, so it's my pleasure to introduce our next speaker, Professor Gong Pei Yun from Tsinghua University Department of Material Science and Engineering. His talk is going to focus on nano drug, especially special function of the drug. So let's welcome Professor Kun.
Thank you, Professor Pan, for the nice and kind introduction. I'd also like to take this opportunity to thank the organizing committee for giving me this opportunity to share with you our research on developing boron nanodrug as a potential drug or as an alternative drug to BPA for BNCT. I really hope that I can convince everyone in this room today that there's a potential of boron nanodrug in BNCT. So what I'd like to do today is to share with you 4 short stories since our group ventured into this field of BNCT, where we first developed our proof of concept work by synthesizing and functionalizing this boron nanoparticle with various polymer ligand, and showed that this non-B10 enriched particle showed at higher anti-tumor effect than B10 enriched BPA. Now, based on this first generation pegylated boron nanoparticle, then we learned really how to install a SPECT imaging agent. This is really a nice tool for us to do in vivo imaging, especially during this drug development stage. Then based on our preliminary SPECT imaging, which I'm going to show you later, we saw some non-ideal characteristic of our first generation boron drug, which then prompt us to design a better, our second generation boron drug. Now, lastly, I'd like to also share with you our current work, which I don't have very much result, but this is a very exciting work where we are developing a boron-rich polymer micelles that is conjugated with a immunotherapeutic compound for a combined immuno-neutron capture therapy. So due to the need of BNCT having a high boron loading at the tumor site, so we've been working on this compound known as boron carbon oxynitride, or abbreviated as BCNO. Due to the high boron loading per nanoparticle, it can be tens of thousands of boron per 5 nanometer particle, which we did a back-in-the-envelope calculation. So this material, BCNO, is very nice. It has an inherent photoluminescence properties, which is very useful for initial in vitro work. We can directly image, look at their bright photoluminescence, and we also take advantage of the non-toxicity of this particle for BNCT. So in summary, we like to take advantage of the high boron content per nanoparticle, their photoluminescence, their bright photoluminescence for in vitro work as a potential boron nanodrug for BNCT. Now, in our first proof of concept work, we showed that we can modulate the biocompatibility and the cell uptake properties of this BCNO particle by varying different polymer ligands around this particle. We also learned that if we coat this particle with a positive charge polymer, we have a much higher boron uptake in a astrocytoma cell. This is the model cells that we use for our proof of concept studies. Now, if we subjected these astrocytoma cells, they were incubated with these different boron particles. They are coated with different polymer ligand, and compare their anti-tumor effect after BNCT with this B10 enriched BPA. We showed that the cell killing effect of this BCNO particle, despite being non-B10 enriched, is still higher than B10 enriched BPA. This is perhaps due to the nano size characteristic of our nanoparticle that have enhanced permeation and retention of this boron nanodrug at the tumor site compared to a small molecular BPA drug. Now, next we learn how to conjugate a metal chelator onto our particle in order for us to radiolabel this BCNO particle for in vivo imaging. Now, we did this by a 3-step synthesis from a commercially available PEG ligand with a universal metal chelator. In this case, we use DOTA. We have also quantified the amount of DOTA per polymer. So we chose to label our nanoparticle with the lutetium-177 due to their availability here in Taiwan, and also due to their 6 days half-life, which is commensurate with the amount of time this particle needs to circulate in the body and get to the tumor site. So shown here is the size and morphology of this particle, of this polymer-coated particle, around 125 nanometer or so, and their hydrodynamic size is in the same size regime. Now, this size, about 125 nanometer, is still within the optimal size regime for nanoparticle drug delivery. So we work with the folks at EINER here. So they help us in radiolabel this lutetium-177 onto our DOTA conjugated PEG-coated particle. And they also did this SPECT imaging for us in this mice bearing triple-negative breast cancer tumor. So we injected this radiolabeled particle via 12-way injection, and from this SPECT imaging, we can indeed see that we do see our particle accumulation at the tumor site, as shown in this yellow arrow. But we also learned that our particle also accumulate elsewhere, especially the liver. And this is perhaps due to the instability of our particle in vivo, which really prompts us to design our second generation particle, which I'm going to show you later. So despite the suboptimal characteristic of our first generation particle, we still went ahead and did in vitro study of this pegylated particle. What's more interesting is that we saw that the intracellular boron uptake of this different polymer-coated BCNO particle supersedes the B10 enriched BPA in this triple negative breast cancer cell. And again, utilizing the inherent photoluminescence of this particle, they emit this green light fluorescence. We can easily see them under the confocal microscopy. And from here, we can qualitatively see that the pegylated particle has a higher internalization efficiency compared to the non-coated BCNO particle. So we also subjected these triple negative breast cancer cells. They were incubated with the bare BCNO particle, the pegylated BCNO particle, and the BPA fructose formulation under similar dosing and under similar neutron flux radiation. Again, we see that the cell killing effect of this BCNO particle is much higher than the B10 enriched BPA drug. So with this, we went ahead to we further extend our studies to in vivo biodistribution of this pegylated nanoparticle and compare their boron loading with the B10 enriched BPA. So if we look at the tumor section here, we see that in all of the BCNO particle, it still exhibit higher boron uptake compared to the B10 enriched BPA, despite the fact that these nanoparticles are non-B10 enriched. So next, we have also looked into what is the effect of BNCT treatment when these mice bearing this triple negative breast cancer tumor, when it is treated with this pegylated particle, BCNO particle, versus mice that are treated with B10 enriched BPA and mice that were just injected with PBS that serve as our control group. As you can see from this tumor growth chart and under the IVIS, mice that were in the BCNO particle group indeed showed a much smaller tumor volume compared to mice that were treated with BPA and mice in the control group. And what's interesting from this tumor growth chart here too, at day 28, where we saw a drastic increase in the tumor growth of mice that were treated with BPA and mice in the control group, while the mice that were treated with BCNO here, the tumor growth here remained quite steady. So because triple negative breast cancer is a very aggressive cancer subtype, and even in the clinic, patients often have cancer recurrent or cancer relapse, even after an initial successful initial treatment. So here we take the tumor tissue section of these mice that were treated with BPA fructose, mice in the control group, and mice that were treated with this pegylated BCNO, and stain them with a couple antibodies. We stain them with p53 antibodies and caspase-3 antibodies. So this the high level of p53 antibody here is a biomarker for cell proliferation. So what that means is that mice that the tumor tissue of mice that were treated that have a high level of p53 means that these mice most likely will have cancer recurrent after recovery. So as shown in this immunostaining result, we see an extensive brown coloration of the p53 stain in the tumor tissue of mice that were treated with BPA, very similar to those mice in the control group. While the tumor tissue of mice that were treated with this BCNO particle here has insignificant brown coloration, which means that there's insignificant expression of this p53 after BNCT treatment.
So in contrast to p53, caspase-3 antibody, it's a biomarker for cell apoptosis after BNCT. So a high level of caspase-3 antibody here signify the extent of cell apoptosis. So this a high level of cell apoptosis really indicates the effectiveness of BNCT in killing this tumor cell. So in contrast to the p53, now here the mice, the tumor tissue of mice that were treated with this pegylated BCNO showed an extensive brown coloration, which means that there's a high level of caspase-3 that were found in these mice that were treated with this BCNO. So combine this result, a high level of caspase-3 and a low level of p53 here really indicates that our polymer-coated BCNO here is an effective boron drug for BNCT. All right, so earlier I show our preliminary SPECT imaging, and we saw some non-ideal characteristic. We saw a high accumulation of our pegylated particle in the liver, which is non-optimal for our case. Now here we hypothesized that if we design a smart nanoparticle, where this nanoparticle that carries a high boron content will disassemble upon arrival at the tumor microenvironment, where the tumor microenvironment is slightly acidic, which causes the polymer linkers that we designed here that has acid-sensitive linker to disassemble, releasing this discrete BCNO particle and simultaneously possess a positively charged surface. Now, this positively charged particle will have enhanced cell internalization efficiency, which we saw in our first generation particle. To design what we call a stimuli-responsive boron nanoassembly, we took the approach of this using this electrostatic co-assembly of the negatively charged BCNO nanoparticle within a neutral charge graphical polymer to assemble this particle into a larger structure which are capable of disassembling later at the tumor microenvironment. So we chose this approach because the polymer, the double hydrophilic polymer here is more biocompatible. We are hoping that our in vivo characteristic of our pegylated nanoparticle will be improved along with the stimuli responsiveness that we are installing in this second generation particle. So first, we developed a model for this electrostatic co-assembly. First, we look at the effect of mixing ratio, X, which is defined by the volume of polymer to the volume of particle. So from this chart here, where the y-axis on the red is the particle size, the second y-axis in blue is the surface charge of the particle. So as we increase the volume of the polymer with decreasing X, we saw that the size of this boron nano assembly increases and passes through a sharp maxima before the size of this nano assembly decreases with increasing volume of polymer. Now, this maxima here is a feature of this co-assembly. It's a feature of this electrostatic co-assembly where we have a complete net charge complexation between the negative charge particle and the positive charge particle, which result in the largest feature of aggregation. So the cartoon showed here basically showed a plausible mechanism based on this electrostatic co-assembly of this negatively charged particle within the positively charged polymer. Shown here are the TEM of the nanoparticle before the co-assembly, and And we saw that these nanoparticle, the size of this nanoassembly decreases as the volume of polymer increases, or a decrease in this mixing ratio. So what is interesting, we saw at the highest polymer volume that we investigated in this study, or at the lowest mixing ratio, this particle adapt a more spherical morphology, which we're still currently investigating. So now we also investigate the pH responsiveness of this particle by incubating this particle at different pH, pH 7, pH 6, and pH 5 over 14 days. Now we saw that the particle that was incubated in pH 5 solution is stable for over 14 days, while particles that were incubated at pH 6 showed a drastic decrease or reduction in the particle size with simultaneous increase in the surface charge. So this indicates that our earlier hypothesis of the cleavage of the stimuli-responsive polymers, which result in the disassembly of this large nanoassembly into smaller discrete nanostructure, BCNO nanostructure, and simultaneous present a positively charged surface charge, which is more cell interactive and could enhance the cell internalization. All right, lastly, I'd like to just briefly share with you our work on this boron-rich polymer micelle that is conjugated with an immune checkpoint blockade. So this approach really takes advantage of the specificity of BNCT in killing the primary tumor and coupled with the immunological response of the host in activating this T cell to kill the cancer cell from the host system. So this immune checkpoint blockade is an antibody that we can conjugate onto our polymer ligand via, again, an acid-sensitive linker. Upon arrival at the tumor microenvironment, this acid-sensitive linker will cleave and allowing this immune checkpoint blockade to block the immunosuppressive PD-1 and PD-L1 axis, which, again, activates the T cell of the host system. So with this, we use a control radical polymerization approach to polymerize a polyboronate ester and blocopolymer, where this polyboronate segment here serve as both the neutron capture and also the hydrophobic segment of this polymer micelle. And we have actually measured the concentration of this immune checkpoint blockade, specifically anti-PD-L1 on our polymer micelle, and measure the size of this polymer micelle to be around 120 nanometers or so. Again, this is still within the optimal size for nanoparticle drug delivery. Lastly, based on this polyboronate ester micelle, we have also encapsulated various cargo. It's very easy to encapsulate various cargo into the hydrophobic core of this polymer micelle, again, to prepare a combined chemo neutron capture therapy. And shown here are the hydrodynamic size and the size under the TEM of this polymer micelle. They're encapsulated with chemotherapy. So we're currently working on in vitro and in vivo work with this polymer micelle. So in summary, I hope I have showed our first generation pegylated BCNO nanoparticle drug as a potential boron nanodrug for BNCT, and showed how we have learned how to label this particle with a SPECT imaging agent, and from our preliminary SPECT imaging here that prompt us to design a better nanoparticle, boron nanoparticle for BNCT. And lastly, I've shared with you our current work in designing a polymer micelle for a combined immuno-neutron capture therapy. I think my time is up. I'd like to thank everyone for your attention. I'll be happy to answer any question if there's any time left. Thank you.
Well, thank you, Professor Kang, for your really refreshing, amazing presentations. Unfortunately, we are out of time, but I'm pretty sure everyone have a lot of questions, and you are going to join our dinner, so I believe that there will be many questions to ask. So thank you again. So I'd like to ask our so it is my great pleasure to introduce Professor Nagasawa Hideko. So Professor Nagasawa, professor is from Kifu Pharmaceutical University, and very importantly, we just learned that she's also serving as a RSC Advances Associate Editor from 2021. So anyone, if you want to submit your paper to the RSC Advances, that will be a really good opportunity to talk to her today. So with that, let's welcome Professor Nagasawa.
First of all, I appreciate for this opportunity to attend such a wonderful meeting, deepen friendship between Taiwan and Japan, and also I also appreciate Dr. Ono for your invitation, and Dr. Yuan Chen, and all those involved in organizing this meeting. Today, I'd like to introduce present our new boron carrier, small molecule boron carrier development. Before I get in main topic, let me first introduce the boron carrier, some of boron carriers I have developed previously. These are the RGD boron cluster conjugate to targeting integrin alpha V beta 3 expressed in selectively tumor cell membrane. For the tumor selective delivery. This compound includes carboron, and also this has a BSH boron cluster. Generally, carbon-containing RGD conjugate was taken up well, better than this compound because of their hydrophobicity. Among those compounds, GPU201 with possessing cyclic RGD peptide moiety, two cyclic RGD peptide moieties was shown the nice boron uptake in the dose and treatment time dependently. And also, it shows significant tumor growth inhibition in vivo experiment. This is another study, the molecular modification of BSH with peptideucin lipopeptide conjugate to improve membrane permeability of BSH. Peptideucin is known to permeabilize membrane by flipping movement. So we predict this molecule penetrate into the cytosol and release BSH by glutathione reduction. So we check the boron uptake to the T98G cells. As a result, 13 PEP was well taken up by cells, dose and time dependently. So this slide shows a neutron irradiation study using this compound. At the dose of 20 micromole of compound and for 24 hours incubation. As a result, 13-PEP and its derivative, 13-PEP-PIP, significantly reduce the cell survival. Cell survival. So, as I have shown here, we have developed large molecules, but today, in this time, I developed a small, simple molecule boron carrier for the synthetic and cost efficiency and those reduction. So we focus on the tumor energy metabolism reprogramming of malignant tumors. As you know, cancer cells obtain energy from glucose by aerobic glycolysis. On the other hand, it is revealed that more malignant and invasive cancer switch to glutamine-dependent energy metabolism. That is called glutamine addiction. So I focus on this hallmark of cancer. For the aggressive proliferation, tumor cells express various aminotransporters. Among them, LAT1 and SCT2 are highly cancer-specific. They conjugate to transport bulky side chain neutral essential amino acid and coupled with glutamine cycle. As you know, BPA is also taken up by the tumor via LAT1. In the molecular design, I refer to the structure of the LAT1 selective compounds such as PET tracers and inhibitors. As you can see, all of these compounds are amino acid with bulky alkyl or aromatic side chains. It is known that polyhedral boron clusters are should aromatic. So carboron can act as useful bioisoster for phenylating and polycyclic hydrocarbons. And this is a popular LAT1 inhibitor, BCH. It also contains a neuronal structure. And LAT1 targeting product consists with targeting unit, tyrosine targeting unit, and cargo. From those findings, I designed this molecule. It is an amino acid containing a carboron as an isoster of a bulky, aromatic, and alkyl side chain. All of these compounds can be synthesized with a simple and expeditious microwave-assisted conjugation reaction we have developed. On the cytotoxicity, using this compound for 20 hours treatment, for any of compounds, little cytotoxicity to T98G cells was observed at these concentrations. So we performed the cell uptake measurement using this compound 10 microgram boron equivalent for 20 hours treatment. As you can see, the only BC2 was uptake very well, significantly higher than other compound. RM value using the reverse phase C8 TLC was measured for this compound for the evaluate the hydrophobicity. BC2, 3, 4 have higher RM values and indicating this, they are highly hydrophobic compared to the BPA and BC1. This is a simple synthetic route for the BC2 from the tyrosine. As you can see, it's a very good, efficient D and E short step to obtain this compound. We also find that in our experiment, BPA hardly taken up into by the cells, whereas BC2 was taken up significantly higher than BPA and dose dependently. Uptake of boron increased until up to 2 hours and retain almost constant with further treatment until 20 hours. So we performed the neutron irradiation study using the TQ98G cells. This is a protocol. To estimate B10 atom incorporated in cells, the cells was washed and suspended in fresh medium before irradiation. By this protocol, we used our compound at a dose of 10 microgram boron equivalent for 20 hours. As you can see, the BC2, only BC2 shows significant cell survival inhibition. We also performed another experiment with a doubled amount, 20 microgram boron equivalent for 2-hour treatment. As a result, D10 D10 become less than half and twice ER. These data show the BC2 would be a hopeful candidate for BNCT. So we try to the mechanistic study using the RAT1 modified SCC7 cells established by Dr. Watanabe and Sanada in Kyoto University. Actually, this experiment is now still ongoing, so I can show the very preliminary result, but BC2 was incorporated significantly incorporated in RAT1 overexpressed cell, significantly higher than wild type and vector transfected cells. But no difference was observed in BPA. The data was not shown here. So the reason for this thought to be the drug would be excreted out of the cells by trypsin treatment. So that's why we changed the cell correction method to method B without trypsinization. By the method B, as expected, BPA and BC2 were taken up significantly higher than method B. So we plan to mechanistic study using RAT1 modified cells and inhibitors, RAT1 inhibitors by method B. The drawback of BC2 is low water solubility, but forming inclusion complex with HP beta cyclodextrin, we succeeded in making a clear solution with a low viscosity. This is the Jobs plot from our previous NMR titration using BSH and beta cyclodextrin. This shows they form the one-to-one complex. And it is also known that boron cluster, including carboron, can be encapsulated by beta cyclodextrin. So that's, and at this experiment, we found that the cyclodextrin beta, BSH beta, HB beta cyclodextrin complex shows a better tumor concentration than usual solution treatment. So we have a plan to the in vivo biodistribution study using the HP beta cyclodextrin and BC2 complex. In summary, we developed the BC2 new boron carrier targeting RAT1. BC2 shows excellent intracellular boron uptake and high cell killing effect by neutron irradiation. So far, we thought the BC2 may be partially taken up by cells by RAT1, and the mechanism is not clear, but they can accumulate and retain in cells. So now we are going to we are evaluating the in vivo experiment near future. Finally, I would like to thank all of my students and staffs for their hard work, and collaborators for their kind assistance. Especially Mr. Yamamoto and Ms. Neitz performed all experiments. They are the undergraduate student, performed all experiments shown here. Thank you for your kind attention.
Thank you, Professor Nagasawa, for your wonderful presentation. So we're going to accept one question. Is there any questions? I have a question. So on page 24, yes. So there are reports saying that attaching a boron cage directly by replacing like the boronic acid from the BPA. So comparing to the molecule that you synthesized, BC2, what's the difference between using a small linker rather than directly attach the carbon ring onto the aromatic ring?
for the synthetic reason, it is very easy to synthesize this molecule. And fortunately, their biodistribution is far different from the directly conjugate to the alkyl chain and aromatic ring. But I don't know the reason, because RM value of this compound are almost same. So that's why, maybe LAT1, if they can transport by LAT1, the molecular recognition is different, I thought.
Okay, thank you so much. Thanks Professor Nagasawa for her presentation.
Thank you very much.
So next, we move to the last talk today. And interesting, Dr. Q is the latest PhD we cultivate in BNCT area in Taiwan. Dr. Q was trained for chemistry in Professor Pan's lab and trained for biology in my lab. Now she graduated in the summer of last year. Now work for Academia Sinica in Taipei. Now we welcome Dr. Q for your presentation.
Okay. Good afternoon, everyone. My name is Shopei Chou, and I'm the speaker today. The topic of my presentation is the synthesis of and biological evaluation of multiple phenylbutyronic acid analogs for boron neutron capture therapy in triple-negative breast cancer. And as you can see, my title is to develop a boron agent for breast cancer. So today I have divided my presentation into 3 parts. I'm going to start with the research background, and I will talk about the synthesis and biological evaluation of multiple phenylbutyronic acid analog. And next, I will come to a summary. And boron neutron capture therapy is a type of cancer treatment that uses boron delivery agent to destroy cancer cells while sparing the normal tissue selectively. In recent years, there have been several developments in boron delivery agent for BNCT, and here are some of the recent developments. These markers are often mimetic biological building blocks, such as nucleotide, as you can see here, or amino acid, and you can see here. And boron-containing polyamine, such as these markers, could uptake by the polyamine transporter system, which is often expressed in tumor cell. And more complex compounds, such as this one, was also developed. As you can see here, is the RGD peptide sequence, which could serve as a targeting ligand to boron compounds to the tumor site. And the next is DBRLA. This marker is comprised of boron cage and linked to the cell-penetrating peptide, so called CPP. The CPP helps this molecule to efficiently uptake by the tumor site via the endocytosis pathway. Given all the above-mentioned examples of this boron agent, it's surprising that structure of PBA could specifically target to tumor sites without targeting ligand. As it turned out, it has to do with the markers named sialic acid, we'll talk about the next few slides. And the sialic acid is used to attach the glycose and GalNAc, a sugar chain of glycoprotein, glycolipid in the form of the residues. And the common links are alpha-2,3,
alpha-2-6, and alpha-2-8. As a possible modification of protein play an important role in biological systems, different modification of glycoprotein play like sialic acid often represent different types of disease and can be recognized as the specific marker, for example. As you can see here, there are 4 different types of cancers. The one that caught our attention is that alpha-2-3 and alpha-2-6 link sialic acid, which are highly related to the breast cancer. This means the phenylboronic acid, such as previously mentioned PBA, could be used for the breast cancer in BNCT. And studies have shown that phenylboronic acid could specifically complex with sialic acid and trigger the endocytosis pathway into tumor cell. It's the reason that PBA could be used to the boron agent which target breast cancer could be developed. And I'm hoping to develop a boron agent that could be used in BNCT to be treat triple-negative breast cancer. The structure of such agent will containing the phenylboronic acid motif that utilize the sialic acid as a biomarker. Before I describe my synthetic strategy, I have used to control this boron-containing compound. Let me elaborate on what is a breast cancer. So if you look at the world stage, that in 2022, the #1 cause of cases is female breast cancers. And obviously, breast cancer become a really important issue that has to be addressed with. Breast cancer can be divided into this subtype based on their biomarker, such as ER, PR, and HER2. And the subtypes are luminal A, B1, B2, and HER2 enriched. So this subtype have the specific biomarker. So he has targeted therapy. However, TNBC are lack of this biomarker to be subjected to the targeted therapy. Therefore, the treatment of TNBC is solely on chemotherapy. And all above the description about the breast cancer and definition of the TNBC, it's very important to know that TNBC is one of the worst type of breast cancers. Although it only happens to 50 to 20% of breast cancers, it's difficult to find the suitable biomarker other than sialic acid or therapeutic target that might be helpful to design any agent for BNCT. Even worse is that high potential for metastasis, high recurrence rate, and poor prognosis when comparing to other breast cancer subtypes. Therefore, it would be very important to develop a suitable BNCT agent for the TNBC. And let me move to the second part of my talk. In this part, I divided to using the multiple containing reaction to construct the phenylboronic acid motif with the optimized condition. A total 18 phenylboronate ester compound were synthesized and remove all the pinnacle ester from multiple remove pinnacle protection from multiple boronate ester is critical for its function, as boronic is known as adapting the character and function of their target. In this strategy, I using a microwave and irradiation for 45 Celsius degree for 30 minutes, and hydrolysis with hydrochloride solution to obtain this 18 boronic acid compound. And conventional chemotherapeutic agent require compounds with IC50 in the nanomolar range. However, the boron delivery agent for BNCT requires the upside. First, we use the BPA as a control to compare with this 18 multiple phenylboronic acid analog. And the second, we're using this 4 cell line, including in normal cell line MCF10A and non-TNBC cell line MCF7 and TNBC cell line. The data was shown in this table. The two compounds, CSD and CG, both less toxicity across all cell lines were tested. Therefore, we have decided to execute the first study of CSD and CG. In this slide, we could observe that bone uptake of BPA and CD and CG was not obviously different in NCF7 and NCF10A. However, the bone agent BPA in TNBC cell line were uptake lower than CD and CG. So, we roughly try to use the bone uptake of breast cancer cell line compared with normal breast cells. For non-TNBC and CL7, the tumor to normal ratio of BPA were higher than 60 and 6G. And on the contrary, the 6G with the highest tumor to normal ratio at 2 hours were higher than TNBC cell line. Therefore, we would use this promising boron delivery agent 6G to execute the first study. And previous studies showed that high metastatic TNBC cell lines express high sialic acid residues. As shown in this slide, the TNBC cell line were treated with sialic death before incubation of 6G, which led to the bone uptake reducing 32% in MDMB231 and drastic decrease in MDMB436. This data would demonstrate the specific interaction of this boron agent with sialic acid epitope on the cell membranes. And the last is evaluation of the anti-tumor effect of multiple phenylboronic acid analog by BNCT. The efficacy of multiple phenylboronic acid derivative, 6D and 6G, were more potent than BPA to inhibit TNBC cell lines. So let me sum up my result here. And 2 low toxicity boron delivery agents were screened out of 18 multiple phenylboronic acid analog. High selective boron delivery agent 6G in TNBC compared with non-TNBC and normal cell line was screened out. We elucidate that the multiple phenylboronic acid analog 6G was associated with sialic acid in TNBC cell lines, and the relationship accounts for about 30 to 50% of the contribution. The BNCT effects of 6D and 6G were more potent than BPA in TNBC cell line. These two boron delivery agent as a potential candidate for BNCT. And I'm very grateful to Above this team to complete this project. Okay, thank you for your attention.
Thank you, Dr. Q. Now we welcome the question from the audience. 中村先生。
Thank you very much. A very interesting, presentation, and I'm very interested in the uptake mechanism of your compound. So you mean that the cyanic acid you conjugate your compound, then accumulate in the cell? It is your proposed mechanism for uptake?
We propose the mechanism is according to the reference show that this slide, that phenylboronic acid, in this reference
have shown that phenylboronic acid could complex with sialic acid and via the endocytosis into the tumor cell.
But in this case, the simple phenylboronic acid is okay.
Yes.
But in your case, you found something, unique structure, show the higher uptake, right?
Yes.
So probably the mechanism is not so simple, I think. What do you think?
Maybe.
And also, I have another question. You showed the uptake, the time-dependent uptake.
Yes, time-dependent.
I wonder why your compound accumulating highly after the 2 hours.
Yeah.
And then dropped in the 4 hours. Usually this cell-based uptake experiment is gonna be increasing and then become plateau. But in your case, after the 4 hours after the administration, the compound,
it flows.
Yeah.
Flow out.
Why? I'm just wondering this phenomenon. Do you have any?
Very.
You don't know. Right. I see. Okay. Maybe if you find clarify the mechanism of the mechanism, maybe they give you some, idea. Yeah. Thank you very much.
Thank you. Any more questions? We are on schedule. Thank you, Dr. Gill. Professor Pan and I have to end this section and hand over the time to Dr. Chen Yiwei. Now, it's your time.
This is the end of this session, and I would like to invite Dr. Chen for the closing remark.
Okay, everybody, today is really a very important day because we resume the communication conference face-to-face again. And we believe we will continue this good tradition year by year. Before we end today's conference, we will invite Professor Ono to give us some talking or anything. No, nothing. Okay. But we prepare a souvenir for Professor Ono. Dr. Pan? Dr. Pan? We prepare a calligraphy and shudo. Yeah. The Chinese character means the real gold tolerate high heat of burning. So we believe BNCT will be splendid in the future. Yeah. This is our souvenir for Professor Ono. Okay, next we will prepare a farewell party in Tsinghua, a very famous restaurant. And later, somebody will take all the participants to join this banquet. So please enjoy tonight's banquet and keep continuing to communication with each other. Thank you very much.